And good afternoon, everybody. Welcome to, this is now the 4th annual Pelvic Pain Symposium that we have here within the Smith Institute for Urology. I'm Dr. Robert Moldwin. I'm a professor of urology at the Smith Institute for Urology, the Northwell Healthcare System, and the Zucker School of Medicine. This is sort of a really neat day because we're going to be broadcasting, I guess, on the web to a lot more people than we usually do. Usually this is a discussion that we usually have with our patients, but we've really broadened up to a much wider community. And today we're going to be we're doing this in collaboration with the Interstitial Cystitis Association and the Katz Institute for Women's Health. So with that, let me just go through some slides with you and go through what this whole agenda is all about. Let me pick this up over here. Great. All right. So as we go through this, just to give you a little bit of understanding, many of you don't know exactly what the Northwell Health, the Smith Institute of Urology is all about. We're part of a very large healthcare system within New York State. In fact, I think we're the largest healthcare employer in the state. And you can see all the dots and the H's for the hospitals. We cover a rather large footprint over here. And our healthcare system with reference to pelvic pain covers these areas as well and beyond. We are really active. We've been active in the field of pelvic pain for a mess of years, probably about 30 years at this point. And as well, we've been active with the Interstitial Cystitis Association. We'll get more about that in a little while. Here you can see some of our past activities, our current activities. The one in red are the activities that we're really hot to trot on right now, very, very active. As you see the third red bullet there, we're looking at inflammatory conditions within the bladder. And Dr. Joel Stern, who's part of our faculty today, will be talking more about the field in general and also some of the wonderful work that he's doing in the laboratory with his colleagues.
Dr. Moldwin?
Yeah.
We're not seeing your slides.
Oh, let's take a look. You know why? Because I'm not very good at this yet. And I need to do my screen share, I guess, right? There we go.
There we go. Thank you.
Thank you. There you go. Well, there's all the big list. And also what we're doing is we're all very active. In fact, I'm very proud of our whole group because many of us were part and parcel of this textbook, which is for clinicians regarding the management, specifically regarding the management of pelvic pain syndromes. So let me sort of back up for a second and tell you how this whole symposium began. As I mentioned, we usually have a symposium for our patients, usually every year, year and a half, and we have different topics that we talk about, just like today. And then we'll have a question and answer. But the problem is that within the COVID pandemic, obviously, a lot of our efforts have been thwarted, and it's just going to be a no-go. We were thinking of doing it as a webinar, but that really started solidifying when we found out that the Interstitial Cystitis Association, which was supposed to have their big walk for interstitial cystitis, also had the same problem. So we put our heads together and we thought we'd make a big, nice meeting for patients. So here we are today, and and it's so wonderful to see so many people participating today. And also, aside from the patients and those who love those patients are being here, I have to give special kudos to everybody, all our faculty today that's spending their weekend during giving these the lectures, and will be part and parcel of the discussions later. Speaking about not being able to get my share screen organized, I have to make a special shout out to Nikki Mahal and Christine Libanati, who have been just unbelievably wonderful as far as organizing and getting this whole Zoom meeting together. So again, I can give you a big round of applause. Nobody, I'm sort of alone in this room, but hopefully everybody's doing the same thing out there. You guys are great, and thank you for putting this all together. So let's get right to it. chronic pelvic pain is a problem, and this is not a lecture series just on interstitial cystitis. We're talking about all forms of pelvic pain, but some of the top players, we'll call them, come under the categories of chronic prostatitis, chronic pelvic pain syndrome, and interstitial cystitis, the bladder pain syndrome. And you can read for yourself now that we're able to share screens here. We used to think these were rare conditions, and now look at this. We're talking about millions and millions of individuals being afflicted. It affects so many parts of someone's life, from their sexual life to their work life to just to their interfamily relationships. It's just can take a tremendous toll. But this is my encouragement slide. This is looking at specific scientific activity as assessed by the number of peer-reviewed articles that are getting out there in the literature on these subjects. So like when I entered the field, which is probably like in the early 1990s, you saw basically almost nothing. I mean, really very few articles or even any interest was in this field. And now if you look at interstitial cystitis and chronic prostatitis syndromes, boom, up they go. I mean, we're talking about, and you can read for yourself the number of scientific articles that are being produced. And I was really happy to see when I just recently put these numbers together and made this chart for you guys, the pelvic floor dysfunction, which we'll be talking a lot about today, and vulvodynia also are starting to get into that curve, that portion of the curve where you're getting more interest. And the more interest there is in the scientific community, the more hopefully we'll see more breakthroughs in the field. So what I want to do before we get started is to just tell you a little bit of our wonderful faculty. This is all in alphabetical order. We have Jen, who is actually my wife. She's her expertise is in female urogenital and sexual medicine. She's part of our group. Lee Lowry, who I've been working with for the past many years as part of the ICA, incredible person, and she's going to tell us a little bit about the ICA in general and what's going on as far as their activities and research efforts. We'll skip over me and go to Marina Rizimovsky, who is a pelvic pain specialist. She is also a nurse practitioner. I call Marina my other head. She is we always are running patients by each other, trying to figure out what the best strategy of care will be. Nancy Silva Mullins, what can I say? I mean, we've been working together for the past, again, it's got to be about almost 10 years at this point. She's the head of our pelvic physiotherapy group, a group of physical therapists who's dedicated to the treatment of pelvic pain. Joel Stern, I can't, if I know that I will just totally mess up the tongue twister of degrees and diplomas that Joel has, but suffice it to say, he is a teacher extraordinaire, a researcher extraordinaire, and he'll give us his insights. And finally, Rosario Teresi, she is a certified sex therapist. She is in our community, and we rely on her services a great deal. Unfortunately, Rosario won't be with us later on for the Q&A, but we do have some, a video of her lecture. So let's get to it now. These are the topics that we're going to be discussing today. We're finished that introduction. Lee Lowry will be talking about the ICA in general. I'll be giving you a recorded lecture. You'll figure that out because I'm in different clothing at the time, about pelvic pain and the pain generator approach. Marina will be talking about medicines that we can put into the bladder to help people and what we've learned over the past many years regarding those agents. We're going to be talking about the role of sex therapy for patients who have pelvic pain. And Nancy's going to be talking about some really interesting things, helpful tools to recovery from a physical therapist perspective. Dr. Stern is then going to go into a lecture on inflammation and how it can cause pain. And the second part of his lecture, it's sort of a two-series lecture, will be discussing some of the advances he's making in the laboratory. Jen will be talking about the role of cannabis, and I'll finish up with the guys who have prostatitis and just not getting better. How do we reevaluate them? And then we'll get into a question and answer. Now, you may notice that not every single topic is relevant to your specific life or your specific condition. My suggestion is bathroom break. Okay, you can always come back. I think a lot of these videos will be available later on. In what format, I'm not quite sure yet. We'll have to speak with the ICA about that. But good opportunities to come and go. Don't worry about that. Take care of yourselves. So with that, I'm going to turn the speaker, microphone, whatever this is, this web, over to Lee Lowry, who'll tell us a little bit about the ICA. So I'm going to stop sharing my screen. I'll let Lee talk, and I'm going to turn my video off.
Okay, I'm hoping that you all can hear me, and I'm hoping that my screen is showing the right thing, and I will rely on my colleague Nikki to let me know if it's wrong. So thank you so much, Dr. Moldwin. As Dr. Moldwin mentioned, I am the Executive Director of the Interstitial Cystitis Association. We are really excited to be co-hosting today's event with Northwell Health. Thank you so much for joining us. Okay, I'd like to take just a few minutes to share a little bit about the Interstitial Cystitis Association. Also known as ICA, we are the only nonprofit charitable organization dedicated solely to improving the quality of healthcare and lives of people living with interstitial cystitis and bladder pain syndrome. Dr. Moldwin has the distinction of serving both on ICA's board of directors as well as on our medical advisory board. ICA's medical advisory board provides clinical expertise on IC and chronic pelvic pain. This multidisciplinary team of urologists, gynecologists, dietitians, nurses, and basic science researchers review IC research grant materials, interpret guidelines and protocols, advise on communications content, and provide a link to the IC clinical, research, and academic communities. We have a magazine that is called the ICA Update, and it's published 3 times per year and is a benefit for donors who give $50 or more annually. We also have a few more excellent resources that you can access online. Our website has a wealth of free information and tools, including the ICA Healthcare Provider Registry and IC support group listings. ICA e-News is our free bi-weekly electronic newsletter. And our Facebook support group is an engaged group for Facebook users who are looking for a place to connect with others who are living with IC BPS and their loved ones. And of course, ICA can be found on all of the major social media platforms. Here is just one item that I wanted to highlight in particular today. Earlier this month, we helped one of our partners, Beaumont Health Systems, promote the launch of an important research study that aims to develop a definitive diagnostic test for people living with IC. Right now, there's no diagnostic test for IC, so this is very, very important. And they are recruiting patients to provide urine samples through the mail to support this study. And so we want to just take a moment to encourage all of you, regardless of your bladder condition, to enroll in this study. It could have an incredible impact on the IC community. It's very simple and it's free to participate. You can find details to participate at icstudy.org. September is IC Awareness Month, and the ICA has put together a robust series of free virtual programming throughout the month to increase awareness about IC. We've branded this month Eye Care Month, and our content is covering awareness, research, and education. Today's event marks the final of 4 of these events we have promoted and co-hosted with our partners. The ICA is able to provide these events because of dedicated donors. We invite all of you who are able to donate at ichelp.org so that we can continue to provide these important educational and awareness events. Thank you so much for taking time to learn about the ICA, and please know that we are here to serve you. Thank you also to Northwell Health for allowing the ICA to broadcast today's symposium and participate for greater exposure and awareness about pelvic pain. Thank you as well to Dr. Moldwin and to all of today's speakers. Now, I'd like to introduce Dr. Moldwin's first session on pelvic pain.
Hello again. I'd like to discuss with you during this lecture a pain generator approach to the management of people who come in with chronic pelvic pain. Why this lecture? Well, I think it's really important for everyone to understand that where we think the pain is coming from may not be coming from that specific area. And also, many patients come in thinking that the pain is coming from one specific organ or the muscles or what have you, when in fact it's coming from maybe multiple sources. So this lecture is really devoted to how we try to figure out what is going on, where the pain is coming from, and how to attack it most effectively. Well, first of all, as I alluded to, lots of people misinterpret where their pain is coming from. A perfect example are men who come with pelvic pain, but they come in with pain at the tip of their penis. There's actually no problem at that point. Really, the problem often is coming from deeper inside the pelvis, whether it be the prostate or the pelvic floor musculature, or even the nervous system. There can be multiple sources of pain, as I mentioned previously. And for example, patients who present with a history of interstitial cystitis, bladder pain syndrome, we often find that, yes, they are suffering from pain related to the bladder, but there may be other sources that are side by side. And in fact, in this particular pie chart that you see over here, this patient has 55% perhaps of their pain from bladder sources, but there's a lot of other pain generators present, whether it be the pelvic floor muscles, that's the PFD, pelvic floor dysfunction, vulvar pain syndrome, such as vulvodynia, and even irritable bowel syndrome. This, of course, will have a great hindrance upon research efforts because, for example, let's say I had a medication that could just wipe out all bladder-related pain, and the patient has this particular pie chart present. Well, of course, only a little more than 50% of the pain at max would be alleviated. You're still left with pelvic pain. And the patients would show this on their symptom scores. They're still having pain. The medication looks like it's useless, but in fact, it really, if you just look at the bladder pain, it would have been useful. Sources of pain may feed upon each other, and a perfect example of this is the bowel-bladder connection. Oftentimes, when the bowel is having a problem, usually problems such as constipation, it may worsen bladder dysfunction. So we may need to treat other sources of pain to have an effect even on other sources of pelvic pain like the bladder. There are lots of vicious cycles that are present that may even perpetuate the pain. And a perfect example of this is found with the pelvic floor musculature. When it starts to spasm, as you can see here, pelvic floor spasm, the muscles are tender. There may be little taut bands of discomfort called trigger points present. When that particular problem exists, patients may have all sorts of symptoms related to pain, changes in the way the urine flows, urinary hesitancy, even problems with constipation, and sexually related pain. And unfortunately, our own normal patients tend to respond to some of those problems by straining. So if you have urinary hesitancy, and that hesitancy is based on pelvic floor spasm, you actually strain the muscles more, and then you have more symptoms. On top of that, let's say you have pain in your pelvis and it may be related to bladder floor spasm. What do people naturally do? They tend to guard. They actually tighten up rather than to relax it out. And that's another little activity or behavioral aspect of this condition that tends to keep this little process of worsening pain in motion. And then you add to this, of course, existing conditions such as vulvar pain syndrome, irritable bowel syndrome, fibromyalgia, even a simple urinary tract infection, along with interstitial cystitis, the bladder pain syndrome, all sources of pain. You tend to guard more, you tend to push more, and again, that spins the cycle. And finally, the last straw is, of course, your stress increases. And what do you do then? You tighten up, and also the physiologic aspects of what occurs during stressful situations can worsen pain altogether. So we need to reverse these processes, and that's so important in the care of patients and getting better. We tend to also think that pain is just from the pelvis, and there was a very interesting study, one of the hallmark findings of the MAP epidemiology phenotyping study. MAP is the multidisciplinary approaches to the study of chronic urological pelvic pain. It's a well-funded NIH project that's been going on for the past 10 years. One of the hallmark findings is that about 3/4 of patients tend to have not just pelvic pain, they have pelvic pain and beyond. We're marking off, as you can see on these body maps, pain in all sorts of different areas of the body, suggesting that this may be a centralized type of global problem for many, many people. And we need to address those issues. To make matters a little more complex, there are all sorts of different forms of pain, whether it's somatic, as you can see the little pinprick over there, you know exactly where it is, which finger the pin is going to, and even where on the finger the pin is hitting. Visceral pain is the type of pain that we see lots and lots of times in the pelvis. And this is the type of pain, it's really hard to describe where it is. It's just hard to describe its character in many instances. It has an emotional component to it, and this is probably one of the most difficult types of pain to identify the source of and even to treat. And of course, there's neuropathic pain that may be from the end organ itself, like the bladder, but there may be central aspects to pain. The pain may be festering in the spinal cord or even the brain. As you can see on this diagram, on this functional MRI study over here, there may be functional changes in brain, changes in brain activity, and even anatomical changes. Whether it's a cause or effect relationship related to the pain is unknown, but clearly there are neuropathic issues involved in many patients that need to be addressed. I mentioned before about the one pain feeding upon another, and this is a perfect example, what we call the bowel-bladder connection or organ-organ crosstalk. You can see here how the bowel, when the bowel becomes dysfunctional, it can have an effect on bladder function as well as pain. It seems to sort of go in one direction clinically more than the other. So when the bladder is having a problem, it doesn't seem to affect the bowel as much, but certainly you can see it from the bowel to the bladder. There are also other issues involved in figuring out where pain is coming from. We see a lot of referred pain. And in this diagram, you can see the nerves that go to and from the pelvic floor muscles over here. And they have a similar input into the central nervous system as the bladder. Now, keep in mind, they have to work together, but that also gives us problems in terms of sometimes problems with the muscles give bladder-type symptoms, and problems with the bladder can give muscle-type symptoms. So that's why it's so important to really do a very close, a very comprehensive history taking and physical examination to sort of better define where the problem truly is coming from. And often we need to treat both issues at the same time. This also reflects something quite interesting, the fact that patients with interstitial cystitis, the bladder pain syndrome, about 80–85% of them will have pelvic floor problems as well. Pain can be difficult, not just from the standpoint of where it's coming from, but how it fluctuates. And we wish all patients, not that we wish pain on anyone, but if you're going to have pain, it's better to just have it straight across over time. Pain severity over time is pretty much stable, but that's really not how it works. Pain can fluctuate every hour, can fluctuate during the course of a day, a week. Patients have symptom flares, and we need to keep this in mind when treating any given patient. We're going to go back to the basics again, trying to find these pain generators, and this is sort of called the cauldron of pain. We have to try to figure out where is the pain, what type of process is going on, and in order to do that, we need to go to the basic concepts of care. We need to identify pain generators, because lots of patients have not just one, but maybe 2 or 3 pain generators, and we need to address them to get the best effect. Of course, history, physical examination, and sometimes we need to do laboratories, x-ray studies, ultrasounds. Sometimes we need to perform cystoscopy to actually see is there inflammatory disease in the bladder, urodynamic evaluation to identify any changes in bladder in urinary function. And then it's a matter of peeling the onion, identify and then treat and then see how patients do. At least that's how we do it, and multiple centers around the globe do it as well these days. Here's a typical patient who may come in. I'm not throwing the easy ones at you. Someone who comes in with lots of problems. It's a 36-year-old female. She carries lots of diagnoses, including fibromyalgia, pelvic floor related pain, vulvar pain, and also has interstitial cystitis. And we may ultimately, after that type of peel the onion approach, come up with a strategy of care that may include a whole bunch of very simple things and more aggressive approaches to care. What goes to which you can see here in this very complex bunch of arrows, but I just want to bring to your attention that there are some problems, for example, pelvic floor dysfunction, that really deserves a special attention. We may apply muscle relaxants, specialized physical therapy, even may inject these muscles specifically with muscle relaxants, with anesthetics, etc. But there are some agents or some therapies that might, basically it's the sort of the one stone, many birds. I hate that analogy, but we're taking a look at amitriptyline, one medication that has been historically used for interstitial cystitis, but its pain relieving properties may improve the symptoms of fibromyalgia along with the interstitial cystitis. And this patient also has vulvodynia. It may have a favorable impact on that condition as well. So we try to sort of organize therapeutic approaches to address all the different problems in as simplified a fashion as possible. Sometimes we need to do more advanced treatments and for specific problems. And this is sort of a little bit of, I guess, a show and tell, if you want to call it, sort of a pictorial approach to what some of the therapies available. You can see here in the upper left-hand corner, specific injections of the muscles that might be tender. This is not a first-line approach for most patients, but clearly it's for patients who've had sort of reached a plateau in terms of the care. We're just not responding. This can be quite helpful. When we can move off to the right side of this slide and see a patient who comes in with a Hunter lesion. This is this little focal area of inflammation. We can fulgurate it, that means to burn it. You can see this outside inflammatory event that occurs, but just by doing this, most patients, the vast majority of patients, will have rapid symptom improvement. We've been advancing that technique further, as is done again globally these days, and injecting triamcinolone, which is steroid, into the region. Here you can see little deposits of the triamcinolone underneath the bladder surface, and what do you not see? You don't see any further inflammatory disease here. So that's a real big win for many patients as well. Typically, when Botox is used into the bladder, it's used for overactivity of the bladder, and you can see it's dispensed in multiple areas. When we use it, we have been using it off-label, as many centers do, for the treatment of interstitial cystitis. It's part of our guidelines, and you can see when we apply it just to this bottom area, which tends to be the most sensitive area, many patients have some improvement in symptoms as well. We move on to some more experimental models. Here you can see this is a description of the use of liposomes, small fat molecules that can surround, in this case, a little droplet of water, but they can also surround medications. And this is what we call a vehicle that can bring perhaps medications to the surface of the bladder, or even other surfaces of the body. Jen has discussed some of the basic issues we'll be discussing the basic issues regarding cannabis. There are cannabis receptors in the bladder and elsewhere in the body that working with these specific agents may have some potential. You can see here the use of what's called neuromodulation, ways to change the way the nerves interact with the bladder and the pelvic floor. You can see these little leads in place. And we're hoping to see more research and work done on how this might help some of our patients with pelvic pain syndromes. And of course, over here, you can see this little side view. This is called the sagittal view of the human body. This is the bladder. And this very, very skinny little catheter that goes directly into the bladder, which is capped off. And recently, we've even been having our interventional radiologists place these little catheters. And the concept here is for patients who really can't tolerate, or for whatever reason we don't want to place a catheter into the urethra, perhaps because of pain or other reasons, we can put it directly over here. Patients can then instill medications all by themselves, cap the tube off, and we can put them through a treatment plan like this. But this is, again, for very selective patients. So in summary, we're going to end over here. Really, the true take-home message here is that pelvic pain is most commonly multifaceted. We usually see not just the bladder or the prostate or the pelvic floor. We usually see a combination of problems for many patients. We need to address those problems. And in doing so, even all the way up to the central nervous system may be in order for many patients. Effective therapies for one problem may have a benefit for other sources of pain. We often treat the pelvic floor problems, bladder pain improves. We treat the bowel of chronic constipation, or the patients do, or their gastroenterologists do. And again, much of their other sources of pain, whether it be the bladder or the pelvic floor, start to improve. So we really have to look at a more holistic approach for patient care. And of course, future therapies really will be developed based upon all the different pathologies that we identify and the specific, what we call the phenotype, how the patients present to us. So I hope this was helpful, and I wish you a very good day ahead.
Okay, so I would thank myself at this point, but I hate making those recordings, but it's so much easier to do these things when you, for these types of programs. Our next up at bat is Marina Ruzimovsky, who's going to be talking about the expanded role of intravesical therapy. This is actually sort of a good segue. That last picture that you saw on my on my lecture had that tiny little catheter that came in directly into the bladder. It's one of the more recent things that we've been doing in a select group of patients that seems to be quite helpful. So we'll start looking at Marina's video.
Good afternoon, everyone, and thank you for spending this afternoon with us today. My name is Marina Ruzimovsky, and I'm a nurse practitioner at the Smith Institute for Urology. Today, I will be speaking about the expanding role of intravesical therapy and what we have learned over the past 40 years. According to the AUA guidelines for treatment of interstitial cystitis bladder pain syndrome, intravesical therapy is the second line of treatment along with physical therapy, oral agents, and pain management. Conservative therapies should always be tried first. Oral agents should be started at the lowest doses. Intravesical agents can be used in conjunction with oral agents and other forms of treatment. However, for patients who exhibit adverse effects to oral agents, bladder installations can be used alone. Intravesical installations can be both diagnostic and therapeutic. For patients presenting with pelvic pain, a bladder installation that relieves pain will point to bladder origin. Cystoscopy will reveal presence or absence of Horner lesions. Horner lesions are relatively uncommon and represent only 5 to 20% of interstitial cystitis population. Most of interstitial cystitis patients simply experience pain with bladder feeling, as well as many other symptoms with absence of visible changes of bladder lining. Bladder installations can be beneficial for both groups of patients and can be used for different scenarios. Cystoscopy and endoscopic injections or fulguration of Hahner lesions can be beneficial for some patients and can only be achieved if there are focal lesions instead of diffusely inflamed bladder wall. A sequence of bladder installations with addition of antibiotic and steroid can aid in reduction of diffused inflammation and hopefully achieve a desirable effect for patients seeking surgical intervention. Those patients who do not benefit from bladder installations and oral agents for treatment of interstitial cystitis could have pelvic pain of other origin. These are some of the recipes of bladder installations. The installations on the left is the most popular in our practice. The therapy is off-label, but can be utilized for patients with sensitivities to oral medications. Studies of individual ingredients instilled into the bladder do not show systemic absorption and can be used in conjunction with oral treatments. The treatment is initially administered weekly and vary in frequency based on patient symptoms. For Hahner lesion patients, increased dose of steroid might be useful. Combination of 2% lidocaine and bupivacaine increases the duration of pain relief. Dwell time of an installation is 60 to 90 minutes. For some patients, alkalinized lidocaine installations are more effective than lidocaine sensorcaine installations. The combination of 4% lidocaine with sodium bicarbonate increases the absorption of lidocaine and can cause systemic side effects such as palpitations and perioral numbness. These side effects arise within minutes of completion of installation and resolve within 30 to 45 minutes. The patients receiving this installation for the first time should be observed in the office for 30 to 45 minutes. If reaction occurs, the installation must be drained from the bladder and the bladder must be irrigated with sterile water. These are known effects of some medications used for intravesical therapy. Lidocaine causes anesthetic effect. Heparin enhances the gag layer that lines the bladder. Steroids cause anti-inflammatory effect, and pentosan polysulfate reduces permeability of the bladder mucosa to toxic urine components. Dimethyl sulfoxide, DMSO, remains the only FDA-approved intravesical agent. It's an anti-inflammatory agent that directly targets the urothelium. It seems to have some analgesic and muscle relaxant properties. Some literature supports that DMSO combined with some other agents is more effective than DMSO intravesically by itself. This is our usual recipe. The common adverse effects of an installation are garlic odor for a few hours after an installation, worsening of symptoms for 24 hours. Full effect of therapy is not seen for 3 to 4 weeks. Call the office if symptoms get worse, as interstitial cystitis patients can get a urinary tract infection. Since some ingredients of anesthetic cocktail contain longer-acting pain relief agents such as sensorcaine, it is recommended not to hold an installation in the bladder for longer than 60 to 90 minutes to avoid urinary retention. Alkalinized lidocaine installation may cause adverse effects that I mentioned earlier, and therefore it's important to keep the volume of an installation low at the beginning, as well as starting with a lower strength of lidocaine, 2% instead of 4%. Some patients can achieve a desirable pain relief with 2% alkalinized lidocaine therapy and might not require higher concentration of lidocaine. For patients with Honor lesions, addition of steroid triamcinolone might be helpful in order to reduce inflammation. Non-Honor lesion patients can do installations without steroids. For many patients, one type of bladder installation might not work. There are other installations that can be tried. It takes time to tailor an individual type of an installation for each patient. Occasionally, after doing a course of one type of an installation, the patient stops responding, and this would be another reason to move on to a different installation. The pain that occurs immediately after or few hours after an installation, I call it rebound pain. As we all know, many interstitial cystitis patients have other conditions that might contribute to pain, such as pelvic floor dysfunction and vulvodynia. These patients may experience more pain immediately after or few hours after an installation. It is important to incorporate heat or cold, muscle relaxants, physical therapy stretches, and other medications to improve the discomfort. For different patients, rebound effect of an installation might be lasting for hours, and it's not unreasonable to consider use of bladder analgesics. In cases of diffuse bladder inflammation, one might consider doing 2 installations per week for the short time to improve pain control and inflammation in the bladder. As many of us know, the treatment of interstitial cystitis bladder pain syndrome is multifactorial and involves many disciplines. However, if therapies do not work, it is reasonable to reevaluate the strategy. Interstitial cystitis patients have many overlapping conditions that require equal attention, and only after a correct diagnosis, the plan of treatment can be established, which might also include agents for treatment of concomitant conditions with muscle relaxants, physical therapy, and topical agents. Interstitial cystitis has negative effect on quality of life, psychosocial well-being, personal relationships, and general health. Interstitial cystitis patients experience more pain, sleep deprivation, and sexual dysfunction. Bladder therapy can be integral for reduction of symptoms and can be used by patients as weekly therapy or rescue treatments. Patients can learn to do installations in the comfort of their home. Learning how to do bladder installations can be done under the supervision of healthcare professional and after establishing the correct recipe for the patient. The patient must learn how to perform a technique of clean intermittent catheterization, mixing correct ingredients of an installation, and self-administration of an installation. It is up to each patient and their healthcare provider to create a schedule of installations and follow-up appointments. For patients who experience urethral pain, as well as pain in the bladder, the installation can be done retrograde first by pushing an installation into the urethra with a small syringe. With time, by desensitizing the urethra, it is possible to move on to a full installation into the bladder or simply use urethral therapy. In many instances, doing self-installations can be empowering for the patients, especially if they reside far from the practice. One's work schedule can't interfere with trying to be in your doctor's office once a week. Another group of patients would like to do a rescue installation during flare of symptoms. Moreover, one can do an installation prior to being intimate with their partner in order to reduce symptoms. Just one more thing. Some ingredients of an installation might not be covered by your insurance, which might be costly. However, if you calculate the cost of taking time from work, your family, and the fact that you must be attached to your physician's office for every installation, the price might be worth it. As I said prior, same installation might not work for two different patients. Therefore, it is important to establish which cocktail works first. Being able to do an installation in comfort of your own home is empowering. It also allows time with your family and participation of family members if needed. If possible, bring someone with you for your teaching session. Support is always helpful. It is often takes more than just a bladder installation to control patients' symptoms. Therefore, a multidisciplinary approach to treatment of interstitial cystitis remains to be a key to successful care of patients. Thank you very much.
That was wonderful. And thank you, Marina. I know I'm not talking to a video because I know you're out there listening. I know it's painful to listen to our own talks, but that's what we're doing today. I just wanted one comment again, and a final thought on Marina's presentation was just that, again, keep in mind that installations are really for people who have bladder, specifically bladder-based pain, and really probably even surface pain in the bladder. They're not for every single patient. You just can't apply it to everybody. And remember, if they have pelvic floor problems or prostate problems or what have you that are outside the bounds of the bladder, it's not going to help. But it can be. If it's part of the problem, it can help that certain percentage. We're going to move on now to Rosaura Teresi. The lecture is going to be about physical therapy, the role of sex therapy for the pelvic pain patient.
Hello, I'm Rosaura Teresi. I go by Dr. T in academic settings and use she, her pronouns. I am the founding director of the Long Island Institute of Sex Therapy and owner of That Drawer, a custom curated erotic boutique in Syosset. So today we're going to talk about pelvic pain, sexual responses, and exploring bodies, whether solo or partnered. Pelvic pain is something that it can occur for many reasons and have many causes. Sometimes there are things that help, sometimes things don't. But overall, the more we know about our own bodies, the better. So being in charge of your care as much as possible is really important. This can mean asking lots of questions from our medical providers. Bringing questions with you is often very helpful. Writing them down in a way, not just on your phone, but actually in a way that's printed out or handwritten on a piece of paper, so that if you're too nervous to ask a question, you can hand that piece of paper over to your provider and say, okay, I have these questions here. You look at them, see if you can answer. But this way, we're not left with only Google or WebMD to help us ask the important questions about what's going on with our bodies. Overall, something to really pay attention to with our bodies is about knowing what something was like before an activity, to pay attention during an activity, and then also afterwards. So we're going to jump into sexual response cycles. And this is generally something that people think of as this linear model where we start here and then end up over here. And then there's this kind of drop and a plateau phase. And that works for some people, but for many people, it's something very cyclical and not such a straight line. Overall, people need to feel a great sense of safety with themselves, with any partners that they're with, in the space that they're in. Spontaneous arousal of this, oh, I'm suddenly horny thing can absolutely happen, but it's definitely not the norm. And arousal has many different stimuli around the world. It can be a temperature, a song, a picture you see, a smell. Those are also things that can also help support an erotic environment for you. So also when we're thinking about doing things on purpose in terms of stimulating erotic desire, that is something that we want to be creating as a whole environment for ourselves and to pay attention to that. Responsive desire is also a part of sexual response cycles for many people. And this can actually trip some people up because they're waiting to feel something in their bodies happening. But sometimes that arousal in the body doesn't happen until some activity is already happening. So it could be, instead of kind of, oh, I saw this really sexy movie and now I'm aroused, or it's 2 o'clock on Tuesday and that's, enough for me. That doesn't always hold true, and it doesn't stay that way, even if it was something that you once experienced. And instead, responsive desire is the experience of engaging in a sexual activity with another person. And then as that's going well, as you're feeling good about it, as the other person's feeling good, that actually is what gets that whole system going in your body. So waiting for that to start isn't always, like, waiting to start sexual activity when your body is already aroused might not actually be the case. This can be really confusing for people, and sometimes especially difficult with any pelvic pain, because pelvic pain can be helped by arousal, or it can be exacerbated or cause flare-ups with sexual arousal. So some people stay away from that sensation in their bodies. Other people feel a little bit more open to different experiences, and their bodies are more relaxed for experiences as they're moving through them. And a part of that is also about, like, the different hormones that flood through our bodies, and just that sense of relaxation that can come through, but also lubrication that can happen, any kind of muscle tension that might build up in some areas could feel great and pleasurable, or not so great. So we kind of, again, are learning through everything that we do whether or not some things are working for us or not, and whether or not we want to do them again. But using things like lube is super duper important. In my practice, I'm often recommending Uber Lube. Good Clean Love has some great lube. There are also the ability to have lubes that have different ingredients in them that can be really supportive. So some people like lubes that feel warming or that are tingling and cool. So those can all be things that are helpful if they help you. So responsive desire is a thing. We know that we're not always just aroused off the bat out of nowhere. Some people absolutely are, but not everybody is. Sometimes we kind of need some activity to start going, and that means even more of a need for this creation of an erotic environment, whether with yourself or with a partner, that you're thinking about all the different sensations in a space. What smells, sounds, tastes, what type of fabric is around you, what, sensations of any lotions or any other kind of tactile, playful things. Like, we think of feathers, or we can think of, at my practice, I have these little sensory gloves that I'll give out to people that have all these different sensations on them to play with. But really just thinking creatively, playfully, how do I engage the senses of my body in a way that feels safe and arousing, or at least curious with myself? Those are things to really start to explore. And I do believe in exploring yourself before saying, hey, cool, here I am with a partner. And, if you don't know what to share with a partner, it can be difficult to have that communication with them of, oh, I like this and I don't like that. But plenty of people really don't have a sense of their sexuality on their own and find that with another person there with them. And as long as there's open communication about what feels good, when things kind of feel neutral and like, yeah, sure, you can keep going, I don't really feel much, or nope, that's really got to stop. If there's language for that, then exploring with a partner before exploring with yourself can be just as fine as after exploring with yourself. Or if you never explore solo, that's okay too. But again, I'm a believer in solo exploration first and then sharing that with a partner. So that's kind of how I'll talk about this a little bit. In overall, we really need to kind of break down what sex means. For so many people, they're caught up in this idea that sex means penetration. It means penis and vagina. And that really is a small part of what sex can really be. Sex doesn't have to be penetrative. It doesn't have to be orgasmic. The umbrella of sex is so wide. And it's so much more than a vagina or a clitoris or a penis and testicles. There's so much that's involved in our sexual beings. You know, like if you think about your body and, you know, kind of no matter who you are, what type of body you have, your penis, your clitoris, your vulva, your testicles are actually a small part of you, as much as they might be a really important part of you. There's still the whole rest of your body to explore and enjoy. This is important for people who experience pelvic pain, but it's also important for everybody that I ever talk to. But it's just important to kind of break it down and realize there's this whole beautiful rainbow umbrella of what can be involved in sex, and exploring that doesn't have to be in like second fiddle to kind of big ass sex of penetrative sex or orgasmic sex. And the idea of a goal of orgasm in and of itself can make sex less enjoyable. So having just this open playground of sex that doesn't have a very specific goal or a specific route to get there is the fun and the journey versus the destination. And that's a really critical part of feeling at one with yourself and able to share a sexual experience with a partner, or even able sometimes to do this thing of like kind of letting go into an experience, whether it's on your own or with a partner. So in terms of understanding your own body first and kind of sharing that later with another person, think about our body parts and what's going on there, right? So the majority of people with clitorises and vaginas need direct clitoral stimulation for optimal pleasure. The majority of people with penises need direct penis stimulation for optimal pleasure. How to do this? So people with penises have external genitalia that are a bit more apparent to them. It's generally easier to see than a clitoris might be or a vagina might be. The majority of people with clitorises can't necessarily easily see their clitorises. And so looking in a mirror is great. Knowing what's there, seeing kind of where folds are, where hair is, where the texture of skin changes. That's all so important to knowing your own body. Many people encounter medical providers over and over and over and over, and those are the people who know their bodies sometimes better than they do. And then when you're thinking about how to enjoy your body sexually, and we have this disconnect of like, well, I don't know my body. How do I know how to share it? So kind of reclaiming some of that also helps with some of the trauma that happens with engaging with medical professionals over and over and being disconnected from your body can be really traumatizing. So kind of recapturing that for yourself and doing that in a way that says, I know my body, I know what it looks like, I know what it feels like, I know what seems to be my normal, where things are, what causes me pleasure, what causes me pain. That's really important and very empowering. So whether you have penis, vulva, and clitorises, whatever is going on for your body, taking the time to explore your body without the objective of, oh, I'm just going to masturbate or have some like solo sex time and orgasm and be done with it, right? But take the time to look at your genitals, know what they're like, know where folds are, know where hair is, know where changes in texture of skin, where lubrication happens, where different sensations feel really loud and powerful, or where they're kind of like dull and feel like nothing. Knowing that about your body is so, so important when we're thinking about sexual pleasure. For people with clitorises, and vulvas, there's a really cool resource called omgyes.com, where you can there's really wonderful videos of people explaining what they do for their bodies, what feels good for them, and then videos that show you what they're doing, and then these really cool interactive videos that if you use your phone or a tablet, or if you have a computer with a touch screen, you can actually engage with the vulvas on the screen to get an idea of what works, what doesn't. And there's a really nice feedback system that's programmed in, where the recording will let you know if you're doing that specific technique correctly. So, you know, moving faster, moving closer to the clitoris, further away from the clitoris, faster stimulation, longer strokes. It'll let you know what you're doing in real time. So later you can take that back to yourself and your own body or a partner's body and try different things. In general, I don't know of any resource like this that exists for people with penises, but in general, we can kind of take some of the information of direct, indirect, different motions and directions and lengths of strokes and things like that, and take some of that information for playing with penises as well. So that's a resource for exploring. The other ideas there that are super helpful are using toys. Use toys, use aids as much as you would like, but maybe even a little more than you might already be comfortable with, because they can open up a whole world of pleasure and comfort. And in terms of comfort, we can think of things like wedges, slings. If we're worried about fluids, there are special sheets that have like a more plasticky underside so that it kind of captures whatever fluids, and then like you put it in the washing machine, over, easy. Different toys that have different accessibility functions. I talk a lot about that, whether it's in my practice, on Instagram, or at that drawer, about how things can be held in hands or placed in different positions on other people's bodies, on pillows or other things around us, so that we can play with them in ways that aren't as cumbersome and more playful and enjoyable. Some toys are more open for those things, for that kind of movement, and then other things are developed specifically for certain issues. Others are just kind of hard to use if you can't use them typically. But I can definitely see that the toy industry is moving to be more accessible for more people, or specifically accessible for certain types of issues, which is really wonderful to see. So things like the O-Nut. So if you haven't heard about the O-Nut, take a minute, go Google it. I think it's O-H and then capital N-U-T. But there are these little interlocking rings that you can make kind of as long or as short as you need them, that cushion for pelvic pain with penetration. You can put the O-nuts together to cause what's going to be penetrated to be smaller, which helps because then the person, if it's their body that is penetrating another person's body, it gives them the same, not same, but a similar feedback of pleasure, of stimulation throughout their body, but not into the other person's body. If it's on a strap-on, then it doesn't matter so much that it can provide the feedback to something like a penis, because it's a strap-on, which doesn't necessarily have the same amount of feedback coming to the person. But either way, the depth of penetration is reduced, which can be very helpful for people who have pain when their bodies have a deeper penetration. So there's that safety again, right? Of like, okay, cool. I know that it's not going to get there. It's not going to get as deep as that place is that then causes pain, and I don't want to do this. So if we know there's safety there, then we can be more comfortable and enjoy the experience. There are also penetrative toys that if you look up if you're using dilators, whether anal or vaginal dilators, and you can see what girth they are, what the dimensions are, the length, then you can start to say, okay, what toys match up to those dilators, right? So when we're thinking about the length of a toy, the girth of a toy, also thinking about like how smooth a toy might be, whether or not we want the toy to warm or be cold or be body temperature. All different things out there. So like I'm talking about this thinking I'm not even doing it justice, because if there's a desire for something, there's probably a toy for it. And if there isn't a toy for it, somebody has talked about a modification for a toy to make it fit that. A really great technique for figuring out, hey, is the toy going to be okay with the different pain issues that I have? Being able to say, okay, this is the dilator that I use. This is long enough. This is, short enough, or this has the appropriate circumference for me to handle and still have pleasure with. It's a really great shortcut for getting there and knowing what's like kind of cool for your body. When you're thinking about sex with a partner now, so these are some of the things in yourself, but again, any of that can apply for a partner, because whatever works for you can then shift over to being useful for a partner. When we're talking about sex with a partner, though, something very, very important is the idea of teamwork, that you're both in this together. This can be complicated, especially if you have a new partner. If it's a long-standing partner that you have, you're more likely to be more comfortable expressing to them what your hard lines are, what you're into, what you don't want to do. You might already have a language with each other. If you don't, or things have changed, it's a really great opportunity for you to say, hey, things have really changed for my body. We're going to need to talk about things that work for me now. The things that were going for me then, this is not working for me. In fact, maybe they're painful now or neutral, and I want to explore what new things could, or different things could actually be pleasurable for both of us here. That's if you have a long-standing partner, it's a little bit easier to do that with. A newer partner, one of my kind of go-to pieces of recommendation for that is the moment you're thinking, I think I'd really like to have sex with this person. I think they want to have sex with me. To say a little bit about that and kind of saying, you know, we might move into a sexual place, we might not. If we do, some things you should know about me are. And then letting them know, you know, if you're having a flare-up or if you have a chronic issue that's always present, what those things are, how to manage around them, or that you'll let them know as things get there, and just so there's kind of the initiation of that conversation before sex starts to happen. If there are any activities that are a no, like any positions, or things that are a must, like contraceptives, knowing what those things are for yourself and then practicing and then being able to communicate them with a partner. So I can't necessarily tell you any particular positions that are better for you. That's really specific. You can kind of know that for most people with pelvic pain that have vaginas, deep vaginal penetration is usually not their thing. It's not going to be what's great. For other people it is. If we're trying to avoid deep vaginal penetration, there's the O-nut. And there's also refraining from positions that have penetration from behind, because that can usually cause deeper penetration, or penetration when you're facing each other. If a person's legs are up, if the person being penetrated, if their legs are up, then that often also causes deeper penetration. Similarly, with somebody with anal penetration, if deeper penetration hurts, using O-nuts can be great, and playing with different angles. I often recommend that whoever it is that is experiencing pelvic pain be the one that's in charge of the depth, the speed, intensity, any of that can kind of play into sexual fun, that they should be more in control of that, especially as people are learning, then reduce the chances of it being a negative sexual experience. Because part of that sexual response cycle is an evaluation moment where you say, would I want to do that again? And if we're thinking about being more sexual beings, then we want to have more sexual experiences that are pleasurable. Again, that doesn't mean orgasmic and it doesn't mean penetrative, it's pleasurable. So you want to kind of stack the decks in your favor and set a situation for yourself that's likely to be more pleasurable, so you might want to do it again. I guess at the end of it all, really the thing to remember from anything that I've said today is that sex is like a playground, and whether you're with yourself or you're with a partner, the idea is to enjoy sexuality, enjoy the umbrella of the experience of what can be involved in sexuality, and to communicate about that with each other, so that if you're communicating with another partner, so that you can really move forward and enjoy more of your sexual experiences together. Thank you for listening to all of this today. I hope it helps.
Okay, we're going to pick it up now. We're going to move on to Nancy Mullins, who will be talking about physical therapy for pelvic pain and helpful tools for recovery.
Hi, my name is Nancy Silva Mullins, and I am a pelvic floor physical therapist with Northwell Health. Today I'm going to be talking to you about some helpful tools that we use in the clinic to manage pelvic pain. So what exactly is pelvic floor physical therapy? It's a non-surgical approach to rehab of dysfunctions in the pelvis that contribute to bowel, bladder, sexual health, and pain complaints. A lot of what we do is patient education so that we can give you the proper tools for your toolbox so that you can self-manage your symptoms. As you can see, we treat a lot of different conditions, but for the sake of today's lecture, we're going to be focusing on the treatment of just pelvic pain. Looking at this, these are some things that we do in order to treat pelvic pain. Again, we spoke about patient education. So what is that exactly? It could be anything from bladder diaries, urge suppression techniques, diet suggestions, to proper posture. All of this impacts your symptoms. We also use therapeutic modalities to decrease pain, manual therapy techniques to decrease trigger points, and relaxation and stretching techniques to just improve overall flexibility. Ultimately, once we achieve all of these things, then we can look to strengthen any weak pelvic floor muscles. Electrical stimulation is a non-addictive, painless, and relatively easy way to help reduce pelvic pain. The electrodes can either be placed on the skin of the painful site, or we can use an internal vaginal or rectal probe that will deliver the stimulation directly to the pelvic floor muscles and the surrounding tissues. That could be the source of the pain. We do use different types of frequencies. There's interferential electrical stimulation. This is used for deeper penetrating tissues, or we can also use TENS, which is transcutaneous nerve stimulation, to stimulate the nerve in order to block the pain. Regardless of the type of stimulation that we use, or if it's external or internal, studies have shown that electrical stimulation has been very beneficial in the treatment of pelvic pain. Low-level laser therapy, or LLLT, is a form of cold laser which uses only light energy to stimulate healing at the cellular level. Surprisingly, the patient does not feel any heat from its use. It promotes vasodilation, which increases blood flow to the area and initiates healing in the tissues. This ultimately decreases any muscle spasms, it inactivates trigger points, and it can alleviate pain and inflammation. Personally, I like to use the laser to the rectal area prior to doing any manual techniques. I found that the patients tend to relax those pelvic floor muscles a little bit more to allow me to do more treatment on them. Lower quarter stretching. Many people underestimate how important stretching is. For example, if you're someone who is sitting at a desk all day, this can equate to tight hamstrings and tight hip flexors, which in turn causes tight pelvic floor muscles, and then ultimately can lead to pelvic pain. So it's important for us as physical therapists to look at the person as a whole and not just hone in on their pelvic floor muscles, because then we may be missing an important piece of the puzzle. Manual techniques are a huge component of what we do in pelvic floor physical therapy. We may use myofascial release, we could do trigger point release, muscle energy techniques, or as shown in the picture, a type of massage technique which is called theomassage. This can be performed either transvaginally or transrectally, with the patient lying flat on their back or on their side. Again, regardless of what position we use, we try to make sure that the patient is comfortable and that they're draped accordingly so that they can relax more to allow us to do more on our part. Viscera refers to the internal organs of the body, such as the stomach, the bladder, the intestines, and these organs actually need to glide in order to work properly. When the organ does not have optimal movement and gliding, then this actually impedes on its ability to perform its physiological functions. So what we do with visceral mobilizations, it's a gentle form of manual therapy that helps to release any restrictions and allow for those organs to move properly again. Skin rolling is a form of myofascial release that we use to identify and treat areas of restriction within painful areas of the body. This can often result in pain, loss of motion, or pressure in that area of restriction. With the skin rolling, we're literally lifting up the skin and pulling it away from those restrictions in order to break up any adhesions. Often patients will have redness or heat to that area that we worked on. They may complain of feeling some soreness. Believe it or not, these are all good signs that it was working. Abdominal massage is an advanced massage to the abdominal pelvic region that we use to treat a lot of gastrointestinal issues, such as constipation or bloating or pelvic pain. We use small little circular motions, starting at the right ASIS, coming up, across, and down. We're basically following the direction of the normal colon mobility. We tend to do this a lot in the clinic, but we also teach our patients how to do this specific technique at home to help them have greater ease with defecation. As a physical therapist, we want to emphasize that coming to the clinic 1 or 2 times a week is not going to cure your pelvic pain. The patient really has to take onus and want to actively participate in their treatment plan. So if manual techniques are beneficial to the patient, a lot of times we recommend that a patient purchase a pelvic wand, which will allow for greater ease performing any self-trigger points or massage to the pelvic floor muscles. Today I'm not going to be advertising any wand over another. I just wanted to show you that there are many different wands on the market. Biofeedback is a big buzzword in pelvic floor physical therapy. It is a way to retrain your pelvic floor muscles. For those patients with pelvic pain, often their muscles are short and tight, and the goal of the biofeedback is to help them understand how to be aware of these muscles and to learn how to relax those muscles in order to decrease that pain. We can use electrodes either on the surface, or again, we can use electrodes that are inserted into the vagina or the rectum. Using a computer screen or a handheld device, the patient actually gets information or feedback to gain more awareness and help them to improve that resting tone. A lot of times with patients who have pelvic pain, I'll teach them a technique of bulging their pelvic floor muscles, which is a lengthening technique. Breathing is so incredibly important. A lot of times when we are under stress, we perform a shallow breathing pattern, and most people with pelvic pain will display this pattern. So we teach them this technique in order to promote relaxation. Vaginal dilators, or trainers as they've recently been referred to, come in all different shapes or sizes. Again, I'm not recommending one over the other, but as you can see, there are silicone dilators and plastic dilators, ones that have magnets to promote increased blood flow, ones that vibrate, and also ones that start at a very small circumference, and then after they're inserted into the vagina, you can push a button and then the circumference actually increases. Regardless of what you get, they are very beneficial for patients with pelvic pain. They provide a prolonged stretch to the tissues and allow for greater ease with penetration. Penetration doesn't necessarily have to be only for intercourse. This can be to help patients be able to insert tampons or just have greater ease during a pelvic exam. Therapeutic stretches, again, very important. we are trying to teach patients things that they can do on their own to maintain all the good work that we achieve within the clinic. I always like to point out to my patients that stretches should be held for a bare minimum of 30 seconds because this is how long the spindles within the muscle fibers take to actually be stretched. So holding a stretch for less than 30 seconds is kind of a waste of time. So really push it 30 to 60 seconds. Going to see a pelvic floor physical therapist to treat your pelvic pain is really not going to cut it. Treating pelvic pain is a multidisciplinary approach, and so in order to really kick this thing in the butt, you should have a really good team. So I encourage everyone to seek out, pelvic pain docs, sex therapist, proper urologist, GIs, or whatever that you may need. I appreciate this, and thank you so much for your time. Take care.
Kudos to Nancy, who did a great job on that presentation. And just to reemphasize, I think a very important point is that not all physical therapists really specialize in the treatment of pelvic pain. To really get the maximum results, and with the concept also, as Nancy was saying, to combine it with other modalities of care. But really, it's so important to have somebody who is expert in the management of pelvic pain. And if you're approaching a physical therapist in your individual communities, and that you have to actually ask them directly, do you specifically work with pelvic pain patients? Because you want to know that they have that specific experience under their belt. With that, we're going to move on to Dr. Stern, who's going to be taught. This is a sort of a two-part lecture. One, a general lecture on inflammation and pain, and the second one on some of his work at our facility. So we'll move straight over to Dr. Stern.
Hi, it's a pleasure to be at the PPTC Northwell Pelvic Health Consortium ICA Patient Consortium. My name is Joel Stern, and I'm an associate professor of neurology, surgery, and molecular medicine at the Zucker School of Medicine at Hofstra Northwell. The title of my talk is Inflammation and Immune Cells Involved in Pelvic Pain. What is inflammation? This is a 1799 illustration of gout. Gout is an inflammatory disorder and reflects how people thought of inflammation as a horrible monster that attacked your body. It was hard to see at the time the positive effects of inflammation, but inflammation is a protective response by the body. So what's the normal role of inflammation? This is a parade, and at the head of the parade is the marshal, directing or coordinating the band where to go. The role of inflammation is to marshal cells at the site of damage and to allow for rebuilding to occur and to regain health. So it's the marshaling of cells and fluids. Inflammation brings in the tools to isolate and destroy and remove damaged tissue and provide the foundation for healing, a balance or balancing of chemical mediators and plasma proteins. The process of inflammation is the same in all tissues of the body. If inflammation occurs at the connective tissue, it's the same at muscle tissue and epithelial tissue, as well as nervous tissue. So the process of inflammation and the cells that are involved in the process of inflammation are the same. It's just that they occur in different locations throughout the body. The connection between inflammation and pain is extremely complicated. Even though you may think or you may not see inflammation in the tissue, you can feel the pain as if the inflammation is actually present. But pain can last as the inflammation has subsided. This is an illustration obtained from a mouse ear, and the experimenter pressed the mouse ear to cause damage. And the veins are all these lines. All of these lines represent the veins, and these little dots represent the cells that are contributing to inflammation. And the dots exist in the blood vessels, and they're there to repair the tissue. So they're the cells that are summoned when inflammation has occurred, and the number of immune cells will actually increase. And this is on the left and the right side. You can see an increased number of these little dots, and every dot represents a particular immune cell. So what are these immune cells that are involved in the process of inflammation? Well, these consist of cells of the innate immune system, such as mast cells, neutrophils, monocytes, and macrophages, as well as cells of the adaptive immune system, such as T cells and B cells. But let's take a closer look at the mast cells. This is a mast cell, and what mast cells do is that they release histamine. And you may be familiar with this from allergies, and they also have a role in fighting infection. They release the histamines to signal other cells that they need to gather at the site of damage and try to fight the infection. And all of these are little vesicles where the histamine is packaged. And again, it's there to recruit immune cells to the site of injury and mediate the immune response. But in order for healing to occur, all of these cells that cause the inflammatory response, they have to be switched off in order to allow for healing to occur. And there are these chemicals in the body whose role is to activate the cells. And these are called pro-inflammatory factors or cytokines. And then there are anti-inflammatory chemicals that try to shut the system off. They shut the cells off that are causing inflammation. And this allows for healing to occur. Sometimes the process goes wrong, and one of these is a result, can result in permanent inflammation in the particular area. So there has to be a balance. So the initial stimulus has to be removed. There has to be a decrease in pro-inflammatory mediators. And what happens if there's a failure? Well, this could lead to a Hunner's lesion, the formation of a Hunner's lesion, this interstitial cystitis bladder pain syndrome, and eventually chronic inflammation, where the Hunner's lesions continue to appear over time, even after treatment. So we studied certain immune cells, and we found certain immune cells at the site of the Hunner's lesions, and 47 biopsies were obtained and compiled for this data. And we measured the number of immune cells, in this case, the number of adaptive immune cells consisting of T cells and B cells and plasma cells, as well as the number of macrophages, neutrophils, and natural killer cells. And you can see that the number of blue bars were significantly increased compared to the number of orange bars, which represent the number of immune cells from an unaffected bladder tissue, as opposed to the Hunner's lesions, where you can see a significant increase. But this doesn't tell you the increase in the proportion of the number of cells compared to an uninfected bladder. And in this slide, you can see the whole bars represent the cells that are present in the Hunner's lesions and a healthy bladder. And these increases are in red, purple, and blue. And so these are the cells that are involved in the inflammatory response of the Hunner's lesions. So there was an increased number of B cells and plasma cells, as well as macrophages that were contributing to the formation of the Hunner's lesion. In summary, inflammation can promote healing, but sometimes it can keep going on when it's not necessary and prevent the healing process from taking place. When inflammation occurs, you have an increase in the number of immune cells in the area of inflammation. And in Hunner's lesions, we see an increase in certain kinds of immune cells of the adaptive and innate immune system. And this gives us more information about the process that can contribute to the pathology of the Hunner's lesions and ICBPS. I'd like to thank Dr. Rob Moldwin for all of his help and guidance throughout for these studies. At the Feinstein, where my lab is located, I'd like to thank Vishan Nursi, William Digavia, and Michelle Laurent, as well as from Northwell Health, Mike Finaro, Oksana Yaksiv, Sonia Balani, and Suhel Najjar. At the Rockefeller, I'd like to thank Ina Tabansky for help of the analysis of the different immune cell populations, as well as Darren Keskin from the Broad and Harvard Medical School. I thank you for your time, and if you have any questions, please let me know. And I'd be happy to provide my email as well if you have any questions after this meeting. Take care. Hello, it's a pleasure to talk to you at the SIU PPTC Northwell Pelvic Health Consortium, ICA Patient Consortium. My name is Joel Stern, and I'm an associate professor of neurology, surgery, and molecular medicine at the Zucker School of Medicine. And I will talk to you today about cytokines and exosomes in ICBPS. And this is the current research that we're currently investigating. We want to understand what kinds of inflammatory signals play a role in the development of ICBPS. And we want to find out if any chemical signals can be used to diagnose or even monitor ICS-BPS progression. This is a microscopic image of cells interacting in the lymph node. We have lymph nodes throughout our body, and the cells in green are T cells, and the cells in red represent our dendritic cells. And you can see how the cells are spending time interacting with each other. They're essentially talking to each other, and they're moving around, and there are multiple interactions that are taking place. And you have to think about when you have an infection or an inflammatory response, that your lymph nodes will swell. And this is basically what's happening. It's you're getting an inflammatory response due to the infection. And these cells will then recruit each other to the site of inflammation, which was the previous talk. And now we're going to take a closer look at the mechanisms of interaction in the next slide. So this is showing essentially a model of an antigen-presenting cell. In this case, an antigen-presenting cell is either a dendritic cell or a B cell, which we learned about in the previous talk. And here we can see that these antigen-presenting cells, or dendritic cells or B cells, present antigen to T cells. It's like they're talking to T cells. So essentially, from the last video that we saw, the reason why you have so many interactions is that the cells are trying to regulate one another. And this is done so that one cell is not overactivated and that each signal represents a specific circumstance. For example, when you try to start a car and you're successful, you have to turn the key, you have to put your foot on the brake, and then you have to put your seatbelt on. These are all safety checkpoints. Well, your immune system has a set of safety checkpoints so that you're not going to activate your T cells, and your T cells won't randomly destroy anything else around the surrounding area. You want to make sure that all of these are specific interactions. There are specific interactions between all of the cells that are involved. It's like when you put the car into drive or reverse, that's essentially like the cells secreting the cytokines to tell the cells where to go. So that's why we need other signals. This is, for instance, there are 3 signals that are required to activate a T cell. This one is, regardless of whether you understand whether this is, it's called an MHC molecule, which is essentially just a receptor. And this is a receptor on T cells. And this is an antigen. So the receptors have to engage one another through this complex. And then there'll be another set of receptors that will engage. This is just called signal 2. And then we'll get the cytokines or chemokines, and these are the chemical signals that will tell the cell where to go. It will give the cell the instructions of where to go. So essentially, the immune cells use these cytokines to communicate, and the cytokines will affect other cell types. And you'll get activation of the immune cells by cytokines inducing these symptoms that arise during the process of fighting an infection, such as when you have a fever or inflammation or the sensation of pain. Inflammation and these cells are always involved in that process. The study that we conducted consisted of 140 patients with ICBPS that generously donated their samples for our study. And these samples consisted of urine, blood, immune cells from the blood, DNA isolation, and we were able to look at the cytokines and exosomes that are involved in cell communication that I'll show you right now, the data. So what we found was we looked for specific cytokines. These are IL-6 and TNF-alpha. These are just specific cytokines that are secreted by cells. And we looked at blood, and we looked at the concentrations on the left panel are concentrations, and below we're comparing patients with different ICBPS, whether they had Hunner's lesions, which is identified as HL, and no Hunner's lesions that were present. These are both patients had interstitial cystitis, bladder pain syndrome. The UC is the control, the unaffected control population. So you always want to compare controls to patients that have other symptoms of the condition. And then we looked at both IL-6 and TNF-alpha, and we found significantly higher levels of IL-6 in patients who presented with Hunner's lesions, as well as increased amounts of TNF-alpha. So both of these cytokines were significantly increased in the urine of the patients. Next, we looked at in the urine, we wanted to see the presence of another way in which cells can communicate. These are called exosomes. And they have good and bad consequences, but essentially they're used for cells to communicate with each other. They consist of lipids, DNA, RNA, and they're found in the blood, urine, saliva, and brain tissue. And what we did is we isolated these exosomes from the urine of patients with ICBPS. And this is just a protein ladder. This is a blank. And we found the presence of unique bands, unique exosomes that were in the urine of patients that had significant course of disease. And they had more than several Hunner's lesions present in the bladder. And in patients that were in remission, you see a much lower amount of these bands, the presence of exosomes. So we concluded that exosomes are present in the urine during different stages of ICBPS. And we're trying to understand the contribution of the immune system to ICBPS. So we're approaching the challenges from multiple angles and using different samples in order to address these questions that we have. And we learned that the exosome analysis we may be able to detect changes in the bladder during ICBPS progression. And we don't know if these changes are a cause or a consequence, sort of like the chicken or the egg, but this research does require more studies and more analysis. So I'd like to thank Dr. Rob Moldwin from the Zucker School of Medicine, who was influential in all of these studies. Our group from the Feinstein Institutes of Medical Research, Vishan Nursi, William de Gavia, and my postdoc, Micheline Laurent, from the Northwell, Mike Finaro, Oksana Yaxi, Sonia Balani, and Suhel Najjar from Rockefeller, Inda Tavansky, and Darren Keskin from the Broad Harvard Medical School. But most importantly, I'd like to thank you, the patients that participate in all of our studies. And without your participation, we wouldn't have been able to make these discoveries, and we wouldn't be able to continue to contribute to the field of ICBPS. So I thank you for your help. And if you have any questions, my contact is provided. Thank you for listening, and have a wonderful day.
Okay, so as you see, Dr. Stern's been very, very busy over the past few years working in this field, and we're so grateful for his work. We need more investigators in this field, and he's one of the real the people I think is going to make big changes in it. So let's move on. We're going to go into the role of cannabis for pelvic pain. Jen Ferriello-Moldwin is going to be talking about this. Jen is actually part of our within the Northwell system, part of the specific committee dealing with cannabinoids and their use in medicine. And she's also a certifier for patients for cannabis use in New York State. So with that, we'll get on to her lecture.
Hi, my name is Jen Barriello-Moldwin. I'm a nurse practitioner at the Smith Institute for Urology, Pelvic Pain Treatment Center. I've been treating women with chronic pelvic pain, vulvodynia, pelvic floor dysfunction, vulvar dermatoses for the past 17 years. I'm also a medical cannabis patient certifier in New York State for the past 2 to 3 years. So today I'm going to talk to you a little bit about the use of medical cannabis for chronic pelvic pain or other types of chronic pain. So first, let's talk about the history of medical cannabis. It has been used for the past 8,000 to 10,000 years medicinally. I'm going to go over a little bit of the timeline. So we first see it in writing in about 2700 BCE. Shen Nung, who's the father of Chinese medicine, first wrote about it in the world's oldest pharmacopoeia. He wrote about something called ma, which is a drink made of cannabis flowers in hot water. And he wrote about its healing properties for all types of different ailments and digestive ailments. Jump ahead a little bit to 1200 BCE, we go to Egypt and the Ebers Papyrus. That's where we first see the use of cannabis mentioned in gynecological conditions. It was ground into honey and put into vaginas to help ease menstrual cramps. 1000 BCE, in India, we see it used as an anesthetic. 79 CE, Pliny the Elder. He first mentioned the use for pain, for all types of different pain, joint pain, gout, so all types of arthritic pains. The end of the 1830s, William O'Shaughnessy brought cannabis to the UK. Dr. John Russell Reynolds, the Queen Victoria's private physician, used cannabis to treat the Queen's menstrual cramps. He put it in a tincture and gave it to her every month. In 1850, cannabis was added to the US Pharmacopoeia. That's the book of all the different drugs that we use in the US for all different types of medical conditions. And in 1850, cannabis was added to that. 1889, The Lancet, which is a big medical journal, first described the cannabis use for opium withdrawal. In the 1930s, all the pharmaceutical companies in the US sold cannabis as medicine. However, end of the 1930s and 1937, the federal government in the United States made cannabis illegal by passing what is known as the Marijuana Tax Act. Just so you know, this was opposed by the American Medical Association. 1941, cannabis was removed from the pharmacopoeia. 1970, cannabis was classified as a Schedule I substance, which means, so in the United States, we have 5 different schedules of all medicines that are FDA approved. Schedule I, anything that's listed on there, no medical value and a high risk of abuse. So just so you know, some substances that are on Schedule I: heroin, peyote, LSD, meth, and acid, and marijuana or cannabis. 1972, the Nixon-appointed Schaefer Commission recommended the decriminalization of cannabis. 1988, Judge Francis Young recommended that medical use of cannabis should be allowed, and it should be reclassified as a prescription drug. Alas, this was the war on drugs in the Reagan era, and that was not put through. So it took until 1996 that California became the first state to legalize medical cannabis. And then on December 20th, 2018, Trump signed the Farm Bill, which made CBD products derived from industrial hemp federally legal. And now, 2020, 33 states in the United States are medical cannabis is legal, and in DC, and in 11 states and in DC, recreational cannabis is legal. And this is just a map of the US, and it shows where recreational and medical cannabis are legal. So this is just some fun stuff. Rob and I were speaking at an IC conference over in Amsterdam, and we went to the Marijuana and Hemp Museum. So this is just some fun stuff that they actually have there. So in the lower left-hand corner, that's actually a prescription that's written for a tincture of cannabis from an OBGYN from 1928. The top left corner, that's an order for opium and cannabis. And as you can see, an advertisement for kidney, liver, and urinary disorders for some cannabis tinctures and some real bottles for cures of rheumatism and stuff like that. So just very quickly, I'm just going to go over the endocannabinoid system. This alone can take 4 hours, a lecture on this. This is very, very, very quick. Endocannabinoid system is an extremely complex system that we are just starting to discover. Endocannabinoids, the two main ones that I want to talk about today are CBD and THC. Endocannabinoid receptors, the two main ones, CB1 and CB2 receptors. There are many more. There are many more endocannabinoids. There are many more endocannabinoid receptors. These are just the main ones that we're going to focus on today. So endocannabinoids and their receptors interact like a lock and key mechanism. However, this system is much more intricate than other receptor systems. So if we think about CB1 receptors, this is a binding site for CBD and THC. This is an example of how CBD modulates the effects of THC. So for example, when you have low CBD, THC occupies that binding site. However, if you have a compound with higher CBD, that will land first on the receptor, making THC binding more difficult. So this is why you can have different strains of cannabis with the same levels of THC, which then produce different medical results. Medical cannabis has both CBD and THC. So this is not just CBD, this is the combination. And when you have both, it produces what's called an entourage effect. So the two of them together potentiate the positive effects of each one. So let's take pain relief. So when you have CBD and THC, you'll get that entourage effect. You'll get pronounced or more pain relief while you decrease the adverse effects such as short-term memory loss, panic, and anxiety that you can sometimes get from just too high of THC. So whereas some people describe it like a lock and key, you should really kind of try to think of it, the medical cannabis, think of THC and CBD interacting like an old married couple. So when I say that, I mean, if you think of them binding at the receptor site, they're going to the receptor site, think of them fighting with each other to try to get to the receptor site because they each want to get there. However, in the end, they really get along best when they're together. So if you just have CBD, it doesn't really work as well without the THC. So that's why a lot of people say, I've tried CBD, it doesn't do anything. You know, I've been on it, I don't really like it, I don't want to use cannabis. But they haven't tried it with the THC because it really does work a little bit better when you take them together. So here are all the cannabinoid receptors where they're expressed in the human body. This is really the CB1 and CB2 receptors. They're all over. So medical cannabis, it's used to treat approximately 105 plus conditions according to the International Society of Cannabis Clinicians. Our knowledge of this system is still evolving. We learn more and more about this all the time. Worldwide prohibition on cannabis has limited our medical research. We are just starting to do real good research on this. Dosing and outcomes are not standardized because we haven't been able to study it because it's a Schedule I. It is still federally illegal. However, thousands of clinicians and patients have accumulated knowledge of cannabis medicine. So we are learning anecdotally. We are learning from each other. We're learning from patients. They come back to us. They tell us their experience. We get together with other clinicians and we learn just by talking and by sharing our knowledge. but there's a steep learning curve. So we are still learning from each other too. So just the American Nurses Association says cannabis has been used medically for centuries. It has been shown to be effective in treating a wide range of symptoms and conditions. Chronic pain. In the US, over 100 million adults are treated for chronic pain annually to the cost of upwards of $635 billion. Current treatments, which I'm sure a lot of you have tried, either are on now, tried and failed, NSAIDs, antidepressants, muscle relaxants, neuroepileptics, that includes Lyrica, gabapentin, opioids, physical therapy, interventional procedures such as trigger point injections and nerve blocks. And this doesn't include all the alternative and complementary therapies that are listed. Pain is the most common condition which people use medical cannabis for, such as musculoskeletal pain, neuropathic pain, that's nerve pain, visceral pain, that's organ pain, so bladder pain, bowel pain. So with cannabis, there's no risk of overdose or sudden death. Even more remarkable, cannabis treats pain in a way opioids can't. Though both drugs target receptors that interfere with pain signals to the brain, cannabis does something more. It targets another receptor that decreases inflammation. And that's Sanjay Gupta, who I'm sure a lot of you know who he is on CNN, who was very anti-medical cannabis. And then I don't know if you know the story, he met this little girl who had Dravet syndrome, who is, which is a form of epilepsy where you can have upwards of 100 seizures a day. Who the only thing that stopped it was a high CBD, low THC cannabis. And he totally changed his way of thinking on medical cannabis. And now he's very pro-medical cannabis for certain conditions. So chronic pain. So just a history of medical cannabis or cannabis and chronic pain. So in the 9th century in Persia, the juice from cannabis flowers packed into the nose of migraine sufferers to treat their headaches. Luckily, we don't do that anymore. We have different ways to treat it, to treat migraines with medical cannabis. It was used during the Civil War, which seemed to decrease the dose of opioid medicines to treat severe pain, which we are seeing today, that the use of medical cannabis is lowering the dose of opioids that people use. And in 1887, Hobart Hare, who was a professor at Jefferson Medical College in Philly, produced a really long article about the advantages of cannabis over opium for treating pain. So jump ahead to today, in like 2015, and Lynch and Campbell looked at 80 studies. And when a lot of these meta-analysis, and meta-analysis means that they look at all the studies and they say, so is this a good thing to do or is this not a good thing to do? And sometimes it comes out saying medical cannabis hasn't shown any efficacy for chronic pain or migraines. So they looked at 80 studies on chronic pain. And when they looked at these, they said, you know what, only 18 are really good studies. The rest are really not good studies. And out of those 18, 15 showed significant analgesic effect of medical cannabis. So 15 showed that it works. So that's, pretty good after you got rid of the kind of garbage studies. Agarwal looked at 38 randomized controlled trials published before 2012 and showed that 71% demonstrated statistically significant pain-relieving effects of medical cannabis. It also showed that the results on chronic pain are very encouraging. However, the results on acute pain are not as successful. And we are seeing that. So when people give medical cannabis for post-op pain, it doesn't really work as well as when you use it for chronic pain. And one of the theories is that when you have these endocannabinoid receptors, you need to take the medical cannabis every day to saturate those endocannabinoid receptors, and then it works better. So Wallace and Furnish also looked at chronic pain and dosing and how much should you take to help your chronic pain. But they found out more is not always better. The low doses of cannabis didn't provide much relief. High doses of cannabis actually increased pain levels. It caused what's known as a hyperalgesia, or it made the pain receptors overstimulate. Moderate doses provided really good relief. So you have to kind of find that sweet spot right in the middle. When we counsel patients, we usually say, start low and increase really slow, just to find that spot because it's very individualized. So you have to find that level where it really helps your pain. So for chronic pelvic pain, how did we start using medical cannabis for chronic pelvic pain? There was a study, Cannabis and multiple sclerosis, that looked at cannabis for spasticity. However, the patients had to keep a bladder diary. And at the end, they found that when they took the cannabis, not the placebo, that their urge incontinence decreased and their bladder control increased. So researchers wanted to find out more about the receptors in their bladder. So they looked at animal models and cadaver models. And what they found out were CB1 and CB2 receptors were in the urothelium, or the lining of the bladder, and the detrusor muscle of the bladder. But they were 2 times higher in the lining of the bladder. Oh, so what if we target these CB1 and CB2 receptors in IC-affected bladders? So Tyagi and Chancellor put something called agilemic acid, which is a selective CB1 and CB2 agonist, in liposomes because it's lipophilic, or it's not water soluble, and put it into female rat bladders for 30 minutes. Then they put something called acetic acid into the bladder. That's to simulate a IC bladder, to make it irritated. And they found that local activation of the bladder cannabinoid system by intravesical or bladder administration can decrease pain signals emerging from the bladder. So activation of the CB1 receptors suppresses the hyperalgesia, and activation of the CB2 receptors suppresses the inflammatory mediators, which provides an analgesic effect for inflammation and neuropathic pain. So the Interstitial Cystitis Network, another patient support group network, did an online survey of its members regarding medical cannabis use in IC patients. So 118 patients responded. 67.5% used medical cannabis within the previous 6 months. 18.2 had a complete resolution of their symptoms. 63.6 had 50% reduction. 14.8 had a 25% reduction. 2 had none, and 1 said that they had a worsening in other domains that they answered questions on. So as far as pain goes, 31.8 had a complete resolution of pain. 55.7 had a 50% reduction of pain. Pelvic floor muscle spasms and tension. 31.3 had a complete resolution of their spasms and tension. 43.4 had 50% reduction. 12 had nothing. However, several patients reported decreased pain with sexual activity due to their decreased pelvic floor muscle spasms and tension. Half of the respondents reported 50% improvement in frequency, and half reported an improvement, 50% improvement in urgency. More than 3/4 reported substantially improved sleep quality, and more than 3/4 reported how many times they get up at night decreased to nothing to at the most 2 times. And finally, flares and flare management. 11% of respondents stated that medical cannabis use triggered their flares. However, when you read their responses, it's because it caused them to eat more food, they said, which they wouldn't normally eat, which they think caused their flares. 89% stated that it did not trigger their flares, or that it stopped their flares before it got too bad. Some other people that looked at medical cannabis and chronic pelvic pain, there was a retrospective study done of 35 women with chronic pelvic pain who used medical cannabis. 82 of those respondents documented a change in pain, of which 79 said that they had improvement. 3 reported none. Nobody had worsening of their pain. And of those 79 who had improvement, 39 reduced their opioid use. Only 9 people had side effects, and headache was the most common. Sinclair, and this is out of Australia, conducted a survey of women who self-manage their endometriosis. 484 women responded, 13% used cannabis. 7.6 out of 10 reported efficacy in pain reduction. 56% were able to decrease their pain medicine by at least half. They reported improvement in sleep, nausea and vomiting, and they reported side effects were very minor and infrequent. Reinert surveyed 364 female patients with endometriosis and or chronic pelvic pain who reported using cannabis or just plain CBD. Use of both, they found, is very common, and both were reported to be very or moderately effective for chronic pelvic pain, with cannabis reported as more effective than just CBD. So other benefits of medical cannabis, in addition to helping chronic pelvic pain, patients also report improved sleep, decreased anxiety, and improvement in other chronic conditions such as inflammatory bowel disease, irritable bowel syndrome, migraines, fibro, autoimmune disorders, in addition to other chronic conditions. Quickly, just a word on topicals. There has been some interesting developments on topical cannabis for dermatological conditions recently. It could have some implications in the treatment of neuropathic pain, such as postherpetic neuralgia, chronic itching, such as eczema, lichen simplex chronicus, and conditions that cause scarring, such as lichen sclerosus. There have not been any studies for any type of vulvar dermatological conditions or neuropathically mediated vestibulodynia. However, that doesn't mean down the line we won't be able to use them. As anyone who has any of these conditions know, we use a lot of things, most things off-label. My hope is that hopefully we'll be able to use these sooner rather than later. However, right now, I just implore you, don't use anything over the counter on your vulva without first checking with your clinician. The things you can buy at the store or at your local, vape shop or wherever, even at CVS, or they all sell now CBD products, have a lot of other ingredients that are not vulvar friendly, or even some men use it for scrotal burning or penile burning. They put some CBD. It can cause contact derm very quickly. I've treated a lot of patients that tried to use CBD on their vulva, and they've come in with a horrible contact dermatitis. So don't use anything without first checking with your clinician. So can you get a medical cannabis card? First thing you do is you check with your state medical cannabis laws. If you don't know what they are, you can Google it. There's a website, leafy.com. You can go on that. It lists every state with all the conditions that are qualifying conditions. So then you check, do you have a qualifying condition? IC is a qualifying condition in Illinois, Connecticut, and North Dakota. However, chronic pain is muscle spasms. They are qualifying conditions in almost every state. Vulvodynia and vulvar burning was added to qualifying conditions in Connecticut in June of 2019. There are some contraindications to using medical cannabis. Pregnant and nursing mothers under the age of 25, certain cardiac conditions, usually unstable cardiac conditions, a history of psychosis or schizophrenia, and there are some interactions with certain medications. Again, check with your clinician. So what is the role of the clinician? So what can they do? When we first started getting into this, there were all these questions. Is that legal? Is this legal? Can I say that to a patient? Because this is technically still an illegal substance. It's still Schedule 1. So federally, it is still illegal. So what we can do, yes, clinicians can fully discuss risk and benefits of medical cannabis with patients. Yes, we can recommend, we can approve, we can endorse, we can suggest. We can use our medical judgment and tell patients that we think you would do better. We think you would do really well with medical cannabis. We can write it in the chart. We can sign government forms. We can sign forms saying that we recommended medical cannabis. We can testify in court. And if you have a clinician that says, I know nothing about this, I can't give you any recommendation, they can educate themselves on the benefits of medical cannabis, different applications. They can say, I don't know about this, but I can recommend you go to see XYZ to go get more information or to go get a medical cannabis card. They can definitely give you some guidance. What we cannot do, we cannot prescribe medical cannabis. This includes writing it on a prescription form and handing it to a patient. It is illegal. It is a Schedule 1 drug. So we do not prescribe medical cannabis. We can certify you to get medical cannabis, and you can go to a dispensary and buy it. We cannot hand you medical cannabis. We cannot take you to a dispensary. We cannot have it in our office and give it to you. and we can't recommend it to you if you do not have a qualifying condition. So in summary, medical cannabis has been used throughout history for various medical conditions. It was used for medical purposes in the US until 1937, when it was then made illegal. So it was used for 90 years before it was then deemed to be illegal. It was classified as a Schedule I drug in 1970, and it remains that way. Today, 33 states and DC recognize the medical benefits of cannabis and have legalized its medical use at the state level. It is still extremely difficult to do placebo-controlled randomized trials because it is still a Schedule I drug. Don't be afraid to speak with your clinician about medical cannabis. If they do not certify patients, they should be able to refer you to someone who does. Remember, more is not always better. Start low and go slow with cannabis. Moderate doses have been shown to provide the best pain relief. Thank you.
Okay, we're gonna finish up with my lecture on pelvic pain in men. This is really basically a discussion about prostatitis syndromes. And then we're going to get right on into the question and answer, where hopefully we'll have a lively discussion. Just to give you a preliminary here, I have a huge number of questions, and that cannabis lecture seemed to stimulate a lot of new questions. So we'll be talking. All right, let's start that video.
Hello again. This lecture is entitled Chronic Prostatitis. It's not always an infection. The reason for this specific title is that so many patients are given a diagnosis of prostatitis. They're empirically started on antibiotics, but the antibiotics, yes, in some cases work, but in many cases they're not working at all, and patients need other forms of care, and that's really what this lecture is devoted to. The symptoms of chronic prostatitis, what we now call CP-CPPS, chronic prostatitis, chronic pelvic pain syndrome, include things like pain at the tip of the penis. And of course, as I mentioned in a previous lecture, the pain usually isn't at the tip of the penis. It's usually way back, either by the prostate or by the pelvic floor muscles. There can be perineal pain. This is pain between the scrotum and the anus, testicular discomfort, urinary hesitancy, the sensation of incomplete emptying, pelvic pressure, constipation. Some of these symptoms don't even sound particularly like the prostate at all. And in fact, some of the patients come in with a lot of bladder-related pain, and it's not infrequent that we ultimately make a diagnosis of interstitial cystitis. Well, the symptoms continue on, and a large part of them may be related to sexual dysfunction. That can be in the form of erectile dysfunction, the inability to attain a reasonable hardness and firmness for penetration, premature ejaculation, ejaculatory pain, and even changes in libido. Well, chronic prostatitis, chronic pelvic pain syndrome doesn't only have, it's not just the symptoms that cause problems, it's the result of those symptoms in terms of social functioning, in terms of stress, depression, anxiety, and so forth. So we really need to keep this in mind, what toll it takes on our patients. Well, let's back up for a moment. Let's talk about some prostate anatomy. And as you can see here in this, what's called a sagittal view, a cross-sectional view, the prostate gland over here sits right underneath the bladder. And on the other side is the rectum. The other side is the sort of the root of the penis and all the structures that allow one to attain an erection. Lots of muscles over here that you see here around the rectal area, and also muscles that control ejaculation. Here you see this on a side view. This is called the coronal view, the prostate over here, and these muscles called the levator ani musculature also. So being in such close proximity, and the fact that the nerves that run in this area also affect the muscles, the prostate, and the bladder, it's sometimes hard to figure out where the pain is coming from. Prostatitis syndromes can be broken down into different categories. And not just for the sake of simplicity, I just want to make mention that most patients that we see in practice and worldwide essentially fall into category 3, what used to be called non-bacterial prostatitis or prostatidynia. The ones that typically everybody thinks about are the first 2 categories, acute prostatitis and chronic bacterial prostatitis. These categories represent maybe only about 5, maybe 10% of patients, but most of these patients will have some history of a documented urinary tract infection somewhere along the way. That leaves us with a dilemma because it means that most patients are not going to respond or minimally respond to antibiotic therapy. So as I mentioned earlier in an earlier lecture, we need to sort of break down the symptoms and where this pain is actually coming from, because it may not just be the prostate. And this is this is something called U-point. It's a way to essentially break the patients down phenotypically, meaning by what we see, how they present to us, whether it be urinary complaints, whether there's, for example, the N stands for neurologic dysfunction, T stands for tenderness of the muscles, and a new one over here, not just U-point, but U-point stands for the sexual dysfunction. And we need to address many of these factors when evaluating patients and ultimately developing a treatment strategy. One of the major players that we see in the majority of patients is some type of muscular dysfunction. And this slide really just goes to show the complexity of this area. So here you can see the phallus here, the anus over here, and all the structures nearby. So you see the nerves that come right over here. You can see its association with these, what we call the ischial tuberosities or the sit bones. And you can understand perhaps why patients don't really care to sit down for long periods of time. It worsens symptoms for so many people. Maybe it's because we're compressing this nerve, the perineal nerve, into these bony structures here. Maybe it's just the fact that we're applying pressure to the nerves and the muscles in this area to cause discomfort. And often on physical examination, we are picking up tenderness in many of these regions, tenderness that we can then hopefully apply some therapies to. One of the basic therapies that we typically apply, and my patients listening today will definitely, they've heard this before, is you need to stop pushing and straining. Many people come in with some urinary hesitancy, or they're just tightening up there all the time because they're in pain, so they guard, they tighten up more, and that seems to worsen this whole cycle of pain. We need to watch out what we're doing in gym, not in the gym activities, because we don't want to inadvertently recruit those muscles and tighten them up and cause more discomfort. At least temporarily, we want to stop doing that. And certainly no Kegel exercises. We want to do the reverse of Kegels. We want to relax those muscles. We want to make sure, remember we talked about the bowel-bladder connection. We want to make sure that that there's no constipation present, and we want to apply usually some heat to that area. We have patients in the bathtub often twice a day, especially when they're not feeling well, and does seem to relieve some of the discomfort, relax the muscles. And to that point, we also, not in all cases, but often apply skeletal muscle relaxants. Really, the cornerstone of therapy is physical therapy, where specialized physical therapists intervene. And I can tell you, again, profound improvements for many patients using very simple techniques and devices, as you can see over here. I mentioned muscle relaxants, and you can see a whole wide assortment of different types of agents that have been used. We often use diazepam, either in pill form or in rectal suppository form. But and this is a controlled substance. We tend to use it only because it tends not to cause a lot of fatigue. But there are lots of other options available in practice. But I really think the take-home message here on this particular slide are not the medications themselves, but the fact that they're only going to take the edge off. No skeletal muscle relaxant will zip into those pelvic floor muscles and take away pain and just relax those muscles. They're going to hit all the muscles of your body. So in order for us to really relax them to a significant degree, we'd have to relax all the muscles of the body, and then you'd be so fatigued you wouldn't be able to function. So it's essentially, I always tell patients, sort of like baking a cake. It's a little pinch of this, it's a little pinch of that. The muscle relaxants are helpful, but you gotta do all these other things, because the muscle relaxants alone, I don't think, are the way to go. And also, you don't want to become just, I need to continue on and on and on. You would like to use muscle relaxants more or less on an as-needed basis, as opposed to taking them all the time, if at all possible. When the level of discomfort really is not, we're not getting there. The patients are either plateauing, or we need to do something a little more aggressive. Sometimes we will reach out to injecting those areas with anesthetics. Botox has been used, but essentially the take-home message here is that we can inject the specific muscle groups and/or the nerves in the area to sometimes calm things down. And sometimes these injections can give patients hours to days to weeks to even months of pain relief. Well, sometimes simple therapies really work well for patients. You don't have to always attack muscles and the prostate directly. Oftentimes, just dietary changes can have a great impact. And I just wanted to bring to your attention the similarities often found between interstitial cystitis, the bladder pain syndrome, and CP-CPPS, the chronic prostatitis, chronic pelvic pain syndrome. How simply spicy foods, acidic foods, alcoholic beverages, and so forth seem to worsen symptoms for not everybody, but for many patients. And sometimes dietary changes are reasonable to move forward with. On the converse side, you can see that there are some medications and dietary supplements that can help improve some of the discomfort. Interestingly, many of them are directed towards improving bowel function, and you can see again that bowel, bladder, or pelvic pain connection. Medications that are available for prostatitis-type syndromes go from nutraceuticals like quercetin, which is a bioflavonoid, to bee pollen, all the way down to more traditional medications such as alpha blockers, medicines that are typically used for prostate enlargement and blockages, to tadalafil, which is a medication when used in low doses, improves erectile dysfunction, to anti-inflammatories, as we mentioned, muscle relaxants, some of the medicines used for interstitial cystitis like tricyclic antidepressants, and even anti-seizure medications. So whole host of different remedies that can be used. Unfortunately, none of them are FDA approved for the treatment of these conditions. There are unconventional therapies, whether it be acupuncture or extracorporeal shockwave treatment. Extracorporeal shockwave treatment is something relatively new, where little mini shockwaves are given usually through the perineum, that region between the scrotum and the anus, to improve pain. In certain very selective cases, nerve disentrapment surgery can be performed, and even prostate massage to perhaps remove some of the prostatic secretions can have some favorable impact for, again, a certain group of patients who perhaps are not responding to other forms of care. But in summary, as I mentioned earlier on in this symposium, chronic prostatitis, chronic pelvic pain syndrome, and all these pelvic pain syndromes are much more common than one might imagine. The symptoms vary quite a bit. Some patients just have sexual side effects. Some patients seem to really have a great deal of pain associated with these problems. It's important to keep in mind, all of us to keep in mind, that these problems can have a significant impact on the quality of life. We are always looking for pelvic floor dysfunction in patients, because that's a quick, simple thing to address. And to keep in mind that very simple therapies, of course, can result in profound improvements. So again, I thank you for your attention, and have a great day.
All right, so we're heading to the finish line over here. And I think if all our faculty can turn their videos on, and I guess you can keep your, unless we have some bad feedback, I think we can keep ourselves unmuted. I'm sitting here with Jen, so she's hanging out with me. We're husband and wife, so we don't have to wear masks together. So that works. So we're good in New York. All right, so we have a whole bunch of questions that came in during the lectures, that came in before the lectures, and I'm going to have to apologize even before we start because there is no way that we'll ever be able to get done with all the, I mean, look, I have a big sheet of paper here and it goes on. So, but we will try. So we're going to try to sort of disperse them amongst our lecturers. We're going to start off with Joel, Dr. Stern. First question is it ICBPS an inflammatory disease or an autoimmune disease? What's your take on that?
Yes, it's an inflammatory disease. It's clearly because of the immune cells that are present at the site of the Hunter lesion. But maybe more work needs to be done to clarify if it fits into the category of an autoimmune condition. And if more in the future, if we look at more the genetics associated with ICBPS Hunter's lesions patients, we'll be able to clarify and maybe move this condition into another category.
So when you say, when you're talking about that inflammatory condition, we're talking about more on the Hunter lesion side, that specific patient group?
Yes, and if the patients that don't present with the Hunter's lesions, there may be a genetic component associated with that disease as well. But such as, for instance, I spoke about the MHC molecules, which were functioning as a receptor to present different antigens. We don't know the antigens involved in ICBPS, but if we do gain that information looking at future studies, we can try to figure out if there is an autoimmune component, meaning that if there's a specific MHC gene associated with ICBPS, then we can sort of gain a better understanding of whether there's an autoimmune component.
I'm going to ask you another question, just sort of since I got you right there on the screen. There was a question about mast cells, and just I know you're not working specifically on mast cells at this moment, although there is some tangential work that we're working on. But can you describe where do you think they fit into the picture with interstitial cystitis?
Yeah, so the mast cells are involved in the inflammatory process, just as macrophages or monocytes are. They're sort of, we don't know whether they're the main driving force of the process, but they're recruited to the area. They release lots of histamine. So essentially, whatever that initiating signal is, whether it's an infection or necrosis or some other initiating factor associated with inflammation, the immune cells will be recruited, and the mast cells will be involved in recruiting other immune cells to this site. It's almost like signaling some sort of damage to this particular area around the bladder.
So just from a clinical perspective, I just wanted to add to that some of the typical medications that we use to treat many of these pain conditions, such as hydroxyzine and even amitriptyline, they do have antihistaminic qualities to it. I know Jen and all of us actually often prescribing Singulair to patients, and all of them, at least in theory, and I put that word in very carefully, theory can be helpful, but we have seen some clinical improvements, and obviously that's why we continue to do so. Let's move on to a question for Nancy Mullins. What is some of the things that can help me at home when I'm in a flare? Anything
Great
from
question.
a physical therapy perspective?
Sure. First, typically the flares tend to come about after some sort of stressful, trigger. So I would really encourage you to try to identify what that is, maybe a change in relationship status. COVID is definitely a huge stressor for all of us. I think we could all benefit from a little therapeutic intervention. But try to hone in on what that is and find a way of dealing with that stress. So whether it's downloading an app such as Calm or Headspace, I would definitely suggest taking the warm baths, Dr. Moldwin, like you had talked about in your previous slides. to promote relaxation of the pelvic floor muscles. And then diaphragmatic breathing is so important. Like I had said briefly, when we are under a lot of stress, we are not breathing correctly. So the pelvic diaphragm, in addition to the respiratory diaphragm, are not working at their optimal conditions. So by just encouraging some diaphragmatic breathing to promote relaxation, that could help calm things down, at least temporarily, you know, and then consult with your doctor or your physical therapist about other things to do.
Oh, great. All right, here's one for Marina. What installation do you usually start with patients, and like what determines how long patients should be on any given therapy?
So as I mentioned in my slides, the most common intravesical installation is the lidocaine gel installations with sensor cane and some other ingredients. And ultimately, this installation is geared towards making nice to the bladder, helping with pain. Some patients find help with urgency, some sleep better. It's very difficult to say which installation will help with which particular symptoms, and therefore I would usually start with once a week installation for maybe 6 weeks duration, and obviously reevaluate every week by speaking with the patient about particular symptoms that he or she experiences. If probably after 6 weeks one particular installation is not helping the patient, at that point I would switch to a different combination, which I've mentioned, alkalinized lidocaine, perhaps DMSO, and so on.
So let me ask you, do you think that, I mean, can you make a few comments about, a little bit more about the self-installations? Because I know you're involved a lot with that. I mean, the benefits, maybe some of the benefits for the patients, again, to reiterate that.
Well, the benefits are great because as much as we love our patients and our patients love us, it's fantastic to be able to do an installation at home. If you're going on vacation and you cannot get into the office for a week, or if you want to be intimate with your partner, if you suddenly have a flare on Saturday at 2 o'clock in the morning, coupled with perhaps symptoms of urinary tract infection, you can just simply take all those ingredients off of your shelf, mix them together, perform catheterization, and make yourself feel better within 20 minutes. Learning how to do an installation and how to mix the ingredients is definitely not difficult. However, I would not recommend to do it at home without any guidance. I would certainly recommend to speak with your medical provider and first of all, establish which installation works best for you, and to make sure that you are catheterizing correctly, mixing the medications correctly, and using everything appropriately.
Yeah. I just want to make a corollary to that. Is just that, you know, there is no perfect installation. Everything, of course, is all off-label. And I think every practitioner has their own, you know, little potion, we'll call it, that they feel is the most helpful for the patient. And you sort of have to, I think as a patient, you have to sort of go with their specific expertise. Here's another question about neuromodulation for pain. Can we say something more about that? I mentioned it very briefly in one of the lectures about things that we do frequently. Neuromodulation, specifically the Interstim, is not FDA approved for pain. It's not approved for. It is approved for urgency, frequency, overactive bladder, and even urinary retention. But it's not approved by the FDA for IC. However, interestingly, it is in our guidelines. So for patients who are failing other therapies, it does seem to work. I mean, this is my bias. We clearly have seen it help pain. You know, Marina, certainly. We've seen it really help some patients who just nothing else was helping. It really was a godsend for them. But I think we try our best to stay still within the guidelines. Most of our patients were doing it on the basis, not just for pain, but also because they have that what we call persistent, what's been termed persistent urgency. They always feel like they have to go. And so it does seem to help them with that. There are new, just so for those of you out there who are even contemplating it, historically these were units that once they were placed, and they're sort of like a regular pacemaker in the lower back, upper buttocks. You couldn't have an MRI after that below the head. And now, of course, the newer units, which are made by several companies now, are MRI compatible, which is just a wonderful one. It just opens the door up for a lot of other patients who would otherwise not have it, be able to have it performed. Let's try one. This is one for Jen. If I tried CBD and it didn't do squat for me, I'm paraphrasing this, will medical marijuana help me?
It may. Again, we suggest that you try CBD first. And then if it does nothing, then maybe, talk to your clinician to see if you are eligible, if you have a qualifying condition to get a medical cannabis card. Again, with the entourage effect or when they potentiate each other, a lot of times the THC and the CBD they work together, and it does work a little bit better than just plain old CBD.
Okay, one for Nancy. I have pelvic pain and urinary incontinence. My friend suggested that I do Kegels. Should I listen to her?
No.
Ooh, get me there.
No more.
I know that most people, when they Google pelvic floor physical therapy, Kegels comes up immediately after that. And we have tons of patients that come in and they say, I have pelvic pain. My doctor may have been telling me to do Kegels even, and we say, stop that immediately. Most patients with pelvic pain, the issue is that the muscle is short and tight. So what I explain to them is we need to lengthen that muscle first, alleviate your pain, and then we can work on the strengthening component. So
let me,
baby
do
steps.
you think there's ever a place in the patient's care, as let's say a patient's really doing well, is there a place sometime down the line where you might consider doing Kegels if they did have incontinence? Is there that sort of in-between place? Yeah.
Correct. So like I said, I would definitely work on alleviating that pain, getting them to a point where, they're able to do all activities pain-free. And then we'd probably start with like a submaximal contraction. So we're not just like jumping right into Kegels, that we're slowly, inching our way into there to strengthen the muscle. But it's really about, and it's not just strengthening at that point, we're doing a lot of coordination. So not only contracting, but also them understanding how to relax those muscles too.
Great. Here's one for Dr. Stern, Joel Stern. What future research is being pursued for ICBPS?
Thanks for the question.
That's sort of a broad question. I'm sorry to.
Right. And so we're actually trying to figure out the specific type of immune cells that are present. So we have the population of immune cells. We detected T cells, B cells, macrophages, and monocytes and mast cells. But now we want to know the subpopulation of those cells that may contribute to ICBPS and the formation of the Hunter's lesion.
So what's the so now like what cells are, okay, you got a bad B cell or whatever it is. So what? I mean, where do you go with that?
Right. So on every cell, there are a set of receptors. So what we're going to do is we're going to try to identify using the state-of-the-art technology in Massachusetts with our collaborators there. And we're going to try to figure out the actual cells, like the name of the particular cell that's going to contribute to the formation of the Hunter's lesions. And if we can figure that out, then we can maybe think about targeted therapeutic strategies.
It's kind of precision medicine.
More like a precision medicine, because when I told you about we found the cytokines that are present, and this is addressing one of the questions in the chat. You're seeing a lot of leukocytes in the bladder because they're being recruited to that site. And then a lot of the cells will die when they enter the bladder. So you're seeing an increase in the leukocytes. And we're trying to figure out, like, if we can stop that process or send the cells to another area, maybe we can suppress the condition.
That's great. And so this is a good segue to another question, which is, are there any new medications on the horizon? Yeah, there are. Okay, so the biggest, you know, I just like I showed you in like one of the first slides when when I was just opening the program up, you see this heightened, the number of articles being produced these days is really, it's hard for us even to keep up with all the literature. It's really popping out there in peer-reviewed journals, which is just so wonderful to see. I think that's a consequence, to be honest with you, with a lot of the work of awareness through the ICA. It's a lot of work, a lot of the epidemiology studies that have been done in the past 20 years also that show this is not a rare, these conditions, not just IC, but pelvic floor issues, all these different things, prostatitis syndromes, these are not rare conditions. And when you see that, when industry realizes that this is a problem here, and there are a lot of patients who are suffering, they start to act upon it, which is a great thing. And that's what we're seeing. I mean, I can tell you that there are, at least I know of, and I can't divulge all the secrets away, but there are multiple companies that are not only looking at medicines to put into the bladder, but also injectables and also pill forms and things like that. The biggest problem we have right now is something that Dr. Stern was really talking about. We know that we're dealing with a very complex and what we call a heterogeneous, not everybody is the same. And you know that not everybody responds to the same therapy. That's why there's so much peeling the onion, hit and miss approaches in this field. But the hope is that, you know, with some of Joel's work, we'll be able to better define who is who. This is a lot of work that the MAP network is also doing. And I think with that, we're going to find better and better therapies, as you say, really targeted therapies. That's what we're going to have to look for. Right now, we're doing the best we can. I think we're doing a pretty good job of trying to sort out, again, the pain generators and then attacking them individually in a multifaceted fashion and helping. But again, getting back to the question, yes, there are a lot of things that are on the horizon. And I think that's cause for a lot of optimism out there. Let's go to another, I'm trying to figure out who could take this one. Marina, why don't we try? Does riding in a car for more than 5 hours cause an IC flare? This is a problem for me right off the bat, but
Riding in a car for
an IC flare.
Riding in a car for 5 hours will cause a flare in any one of us. However, I would speculate, yes, you do need to stop ever so often and empty the bladder because, of course, overfilling of the bladder, especially in Hunter lesions patients, will cause significantly more pain. Hunter lesions patients might sometimes have bleeding. Non-Hunter lesions patients also will experience pain with bladder filling. But
what about the guys with prostatitis? Forget that. Let's move over to the guys, and also obviously there are men with IC as well. Many men with IC.
No, the guys with prostatitis most definitely will also experience more pressure, more pain, sensation of discomfort at the tip of the penis, and all other symptoms as well. But I wanted to also say that, you know, many of our patients, as everyone knows, have pelvic floor dysfunction. So combination of both factors, and sitting in the car for 5 hours, definitely not a good idea. I usually tell patients, you know, stop every 60 to 90 minutes, walk around your car, go back in and drive for another hour to an hour and a half, or, you know, from bathroom to bathroom, something like that.
And some people actually, you know, it's an interesting thing. Maybe Nancy can say something about this. What about car seats? Is there anything you suggest to patients? Soft, hard, anything special there?
Nothing special. I mean, you know, some people will ask about a lumbar support roll just to get them into a better posture. Okay, sure. I would say you don't necessarily have to spend your money on anything expensive. I say take a rolled up sweatshirt and just put it into the small of your back and just keep adjusting that over the course of the trip. But what I was also going to comment, like Marina said, make sure that you're taking those stops, because as we're sitting in the car, I mean, all of us now on this call for 3 hours, I'm sure we're all slowly slumping in our chairs like this, and our posture, you know, and we're going over like this. So our postures are definitely affected, and, you know, sitting for that amount of time, you're going to get some tightness, especially in your hip flexors and your adductors, which all attach to the pelvic girdle and can affect the pelvic floor muscles. So definitely getting out, maybe doing a couple of stretches, walking around, so that could help.
Great. Jen, this is not quite on CBD, it's just a general, I guess, sort of a vulvodynia question. Toilet paper ingredients, wiping, do you think that could, do you find that that is bothersome to certain patients?
Toilet paper ingredient?
Well, the type of toilet paper, or?
I mean, I would just stick with something unscented. I wouldn't get scented toilet. I don't know. Do they make scented toilet paper?
Yeah, I think probably. I mean, somebody's got to do it.
You know, I would say stick with unscented cotton, natural toilet paper, and no wipes, no baby wipes.
Why is that?
They can be very irritating, and sometimes they're scented. Sometimes they have alcohol. I would no baby wipes.
Oh, they're okay.
Especially if their vulva is already irritated, it can cause like a contact derm.
Okay, all right. Well, with the COVID pandemic, many of us have had to use different types of toilet paper, as everybody knows out there. So
I'm trying to stick with
yeah,
unscented.
okay. Yeah, sometimes you do what you have to do. So right. There's a question about a TMJ link and pelvic pain. That's a really interesting topic. We've all been really quite interested in that topic. We're finding. We've seen this for years and years. We would have patients coming into the office, and you would actually watch the muscles in the jaw, the masseter muscles, go clenching constantly throughout an initial visit with any given patient. And then when we would go to examine the patient and listen to their history, the history of the illness, we come to a diagnosis of pelvic floor spasm. We would find these very tender muscles in the pelvis in either men or women. And we almost we ultimately realized, boy, this clenching of the jaw was almost like a marker for many people of what was going on down below. And it also suggested to us that perhaps this type of tightening that so many people do, this guarding behavior that they do in their pelvic floor, it's sort of a global process. They're also doing it here. Now, do all these patients who do this have, classic TMJ symptom, headaches and pain to touch and so forth and so on? No, but it is in observation that they do this. But again, when you're constantly, from a behavioral perspective, if you're constantly tightening up and you have that tendency towards discomfort to begin with, it's probably not going to do you any good, and you have to be aware of that, and a little more self-awareness. That's where physical therapy can be so instrumental. Even techniques like meditation, yoga, we always are recommending these types of activities for patients, because I think all of them really help calm that down and allow you to have better control over your own body. Let's find another one. Botox. Let's talk about pelvic congestion syndrome. So pelvic congestion syndrome, do you want to take that? No? All right, I'll take it. So nobody wants to answer questions here. So pelvic congestion syndrome, it basically is something that's primarily described in women. We have seen something similar in men. And essentially, we have blood vessels all over our body. And I think, and there are an innumerable number of blood vessels in the pelvis. Sometimes they can become over-distended, congested, much like a varicose vein that you might see in someone's leg, but in this case, they become swollen, and in some instances, that swelling can lead to discomfort. It is in the differential diagnosis of pelvic pain. When someone's pain almost goes away completely when they lie down, but it seems to get worse when they stand up. It's not necessarily related to bladder, right? Because why should that get worse with bladder filling and emptying? Yeah, at least we have to start thinking of, what's that?
Vulvar labial varicosities,
right?
As you can see.
As Jen mentions, in some instances, you can even see some of these varicosities stem out to the vulvar tissue, to the labia itself. So if we suspect it, We will send patients to our radiology colleagues who will do special studies, whether it be MRIs or special studies where the veins themselves are injected, and they can block those vessels, and hopefully the patient's symptoms settle down. So it is in the differential diagnosis. We don't see it all that frequently. The biggest concern, of course, that we always have is just because you have a finding does not necessarily mean that the pain is coming from there. And a perfect little example of that, of course, we see all the time is something like endometriosis. Lots of people probably have endometriosis, but is their pain truly coming from that particular problem? So that's one of the dilemmas in the treatment of any type of pain, no matter where it is in the body. Is it a cause and effect issue? Let's move on to actually I'm going to move on to a topic that's fairly controversial right now. It really does have to do with interstitial cystitis, and it has to do with Elmiron, or pentosan polysulfate sodium. The big question, that we have a ton of questions from this that came in even before the conference started, on is it safe to use? And that question arose because of some recent literature that suggests an association between long-term, often high-dose Elmiron usage and the development of something called a pigmentary maculopathy, which is a condition where one can start to lose their vision. I'm not going to give you all the, but it's blurry vision, difficulties with night vision, sometimes straight lines seem to be curved, and so forth. So, I mean, in my own experience, I have not seen any patients with this specific condition. I suspect it's relatively uncommon. If a patient does have pre-existing eye problems and they've been on Elmiron, I'll usually tell them to see an ophthalmologist. It's just sort of common sense kind of thing to do. Certainly if their vision is worsening, yeah, they definitely need to see an ophthalmologist irrespective of that. The question is, should patients get a baseline exam? I don't see any downside to it, but I think we'll find out more, down the pike as we learn more about if there is any type of true cause and effect relationship here. There is some additional, there's always a package insert with every medication that's FDA approved. And right now there is an addition to the package insert that mentions this particular issue. I know that the ICA, as Lee had mentioned earlier on, I'm on their board of directors. So the group put out a basic statement about being cautious with it. But do I think every patient should be coming off of it? I think that's something you have to discuss with the individual practitioners, and I would leave it at that. Can IC cause back pain? Marina, you want to take that?
Yes, IC can cause back pain for sure. Would the IC directly cause the back pain? Again, I'm not convinced 100%. I would probably, again, pile the IC together with pelvic floor muscle spasm, and actually also vulvodynia. As we know, many patients also complain of, pain with sitting where they have vulvodynia. But yeah, combination of pelvic floor and IC will definitely cause back pain.
I'll tell you, my impression has been that, lots of people have back pain. It can occur irrespective of any type of pelvic pathology at all. I agree. I think that certain types of bladder pain can be referred back, to the, but Nancy, what's your take when you're doing pelvic floor physiotherapy of any so whatever modality you're using? Do you see a lot of the back pain settle down when you're actually addressing pelvic floor related issues? What's your take on that?
Yes. And a lot of times patients will they may go to an orthopedic physical therapist who can only, obviously look at them from the outside. And then it's not until I start doing maybe some internal work So I can really get into those muscles and palpate the piriformis or the obturator internus, that really releases the muscles then, and then they get some back relief. You know, a lot of times patients come to me for different diagnoses like constipation or you know, men with prostatitis, and they didn't even realize that they had back pain until I start working on them. They're like, oh wow, it feels looser. So that does happen quite often.
I'm going to ask Jen a question. Will medical marijuana make me high?
It should not. Again, because it has CBD and THC, the CBD should mitigate the psychoactive effects of the THC. In most states, this is not recreational, this is the medical cannabis. There are only certain ratios that you can get because it is standardized for medical use. So it should not make you high, or sometimes people on the higher ratios of THC to CBD, people can get a little bit tired. Maybe they mainly feel a little bit tired. Sometimes they get a headache or so, but they shouldn't get, quote, high from it. The lower doses, they really should not have those psychoactive effects at all. And but again, everyone responds differently. So I'm not going to say no across the board. Everyone responds differently, but it really should mitigate those effects.
All right. I had a good one here. Let's take a look here. Oh, are there pain options other than Aleve, Pyridium, and Elavil? I think I'll just take that one. That's pretty straightforward, I guess. So Aleve, of course, is a anti-inflammatory, a non-steroidal anti-inflammatory. Pyridium is a medicine that seems to act directly in the bladder, so it takes away burning type pain. And amitriptyline or Elavil is a tricyclic antidepressant. Again, not a medicine that's been used, that's FDA approved for IC, but is really a staple medication in the realm of pain management. There are lots of other medications that can be used. I sort of went over some of those in the prostatitis lecture. If you're a guy, there's even B-palm, there's quercetin. There are what are called alpha blockers, which tend to relax the neck of the bladder. Again, the disclaimer is all off-label, of course. Beyond amitriptyline or Elavil, there's a sister of Elavil called nortriptyline. There are anti-seizure medicines like gabapentin or pregabalin. There are lots and lots of different medications. And then, of course, we have other realms, and we go up in terms of how aggressive to be. We can put medicines in the bladder if it's an interstitial cystitis patient. But then we start talking about other more aggressive approaches like let's say, stretching the bladder, burning the bladder wall, or what have you. We could do trigger point injections if there's which I can get into, that's another question. If there's still a great deal of pelvic floor tenderness present. So yeah, there's lots of different things. And just keep in mind, we also very, very frequently, we have a very close relationship, as many people practicing in the realm of pelvic pain do, have a very important relationship with our pain management colleagues. So they're either anesthesiologists, usually anesthesiologists, or neurologists. And they are immeasurably helpful at helping our patients, as well with other things that perhaps your urologist or the urogynecologist you might be working with or not don't feel that comfortable with. There is another question about what are the current treatment for these Hunter ulcers, or what we now call just Hunter lesions. I sort of showed that on one of the pictures, on some of the pictures that I had earlier on. Maria, at least okay, so let me back up for a second. Any patient who has these inflamed areas of the bladder and they're having pain, they may have pelvic floor problems. They may need to see the physical therapist. They may be having sleeping problems, and amitriptyline is incredibly helpful to them. And so all those lower levels of care, even dietary changes, everything, they're all on the table for patients who have Hunter lesions. Just because you have a Hunter lesion doesn't mean we have to, do all sorts of fancy surgeries on the bladder wall. But if they're not working or the patients are plateaued, they just can't get right, then that's when Marina gets to work and starts working, with bladder installations of various sorts, as she noted. And it's also a time when we start to think about doing burning or injecting these areas with a steroid. In our case, we use triamcinolone, and that's pretty much around the globe at this point. It seems to be a fairly consistent form of care. There are even more aggressive forms of care. We can use cyclosporin, which is an immunosuppressant, which sort of gets into Dr. Stern's territory, a specific attack on the immune system. The downside of that is, of course, as you may see all the commercials in the morning for Humira and all these things, there's a big disclaimer after that, that this could open you up to malignancies, easier to acquire infections. And certainly cyclosporin has other downsides to it, namely hypertension, high blood pressure. It can affect your kidney function, et cetera. So we use it judiciously. We use it with caution. But I think the patients we have used it on have done phenomenally well. I mean, it's really remarkable. So these are the levels of care that we provide any given patient. We work from conservative to the more aggressive approaches. All right, we have a few more minutes left. Nancy, could you give us there's a basic question because we talk about pelvic floor dysfunction so much. Can you give us like a definition? What's your take on what is pelvic floor dysfunction?
Pelvic floor dysfunction, I typically tell patients that if your doctor gives you pelvic floor dysfunction as a diagnosis, it's kind of like a garbage pail term. It can mean anything, because they come in and they're like, well, I've got PFD. And I say, well, what is that exactly? That could be pain, incontinence, constipation, it could be one of so many things. And I also relate that to sciatica. I could say I have sciatica and it's buttock pain, and you have sciatica and it's pain that runs, down your leg. So specifically we say, what are your symptoms, so that we can get a better idea as to what they are experiencing. But ultimately, it's that their pelvic floor muscles are not working the way that they're supposed to. So it's really a coordination issue. Maybe they have a higher resting tone, and that's contributing to some of the pain. Maybe they're unable to relax. That can be contributing to urgency, frequency, pain issues. A lot of times, I say, if you've seen the movie Shrek, it's like an onion. You start peeling away all of these layers, and it's, the patient only knew that they had pelvic pain, and as we start talking, it also turns out that they find out, oh, I've been straining when I urinate, and they didn't know that they're not supposed to be straining when they urinate. And you find out all these other symptoms. So it's not as cut and dry. You think you're going to get an easy case, and it's like all of this just falls out in front of you. So but basically, do you think does pelvic floor dysfunction, so pelvic floor dysfunction is a very broad term. Yes.
So when you have a patient, for example, comes in and you touch those muscles and it's terribly painful.
Correct.
Is there a specific category of pelvic floor dysfunction? What do you call that specifically?
No, I think at that point we're just grading, the tenderness of the muscle itself. And again, more so looking at the coordination. What we're looking at is, can they contract, can they relax, and can they also bulge their pelvic floor muscles?
Right, so you're looking at not only, of course, just pain, you're looking at their function as well, functionality,
Correct.
which is all very important. And of course, that may speak to the fact that patients have pain, but some patients, for example, they have more of the irritative symptoms, right? They're not coming out right? Right. I always feel like I have to go to the bathroom, but you might touch the muscles and they feel they're not really tender, but they still could be dysfunctional.
Correct.
Got it. Okay, so that's great. I'm going to finish up with one question that keeps on. I think people are sort of anxious to hear about trigger point injections. Trigger point injections are that's a whole long lecture, but trigger point injections are usually the way we perform them. When we have a patient who has specific pain sites in muscles in the pelvis, whether or not they have interstitial cystitis or prostatitis syndromes, if we can identify or we believe that that's a pain generator, what we will often do is we'll inject the muscles directly, just like I showed in that diagram, and usually it's in the office setting with an anesthetic. So there are two edges to this. One is diagnostic. If much of the pain goes down when we put the anesthetic directly into the muscles, then we realize, well, that's probably the site of that's where the pain's coming from, because now they're anesthetized and the pain's gone. So it helps to identify that as a pain generator. The other really neat thing is that in many patients, it doesn't, so typically these medicines should last only about 3 to 5 hours if they make you feel better, but oftentimes they help people for days or weeks, and we have patients even, as you all know, can go on with little pain for months after these injections. So I think they have been very helpful, I think, in terms of treating patients who have sort of plateaued. You guys in physical therapy have been working. We've been working with medical therapy and all sorts of different other modalities. And when we just can't get there, this has been helpful. Other practitioners are using these injections more upfront in the care of patients. That's just not our practice. Other people and we also have been using off-label Botox in these areas, which also works on a different principle. Of course, it works by relaxing the muscle tissue. It does have some pain alleviation qualities as well. So that also, not to get too far into it, but that can help a subpopulation of patients as well. So I think I wish we could, I see all sorts of more questions, but unfortunately our time is out. And I really thank all of you guys, all the participants for attending. It was so wonderful that you would take some time on your weekends and on an afternoon like this. At least it's fairly nice in New York right now to spend time with us. And I really have to thank our faculty, who are just dedicated, wonderful, wonderful people, just to do all this. Really out of the kindness of their hearts, because they really feel passionately. Everybody here, I know, feels very passionately about getting patients the best care possible. And once again, I thank the Katz Institute for Women's Health for promoting this. And God, you guys in the ICA are just awesome. I thank you so much. We all thank you on behalf of all your efforts as far as patients are concerned, and moving this field in a great direction. So everybody, please stay safe out there. It was wonderful being with you. Hope we do it again under better circumstances, though.